Talking about osteoporosis, and I'm pleased to introduce Dr. Shakir, who's a senior consultant in orthopedic in our polyclinic and family medicine department, King Faisal Hospital. And I hope you will enjoy the lecture. With no further delay, please welcome Dr. Shakir.
Bismillah ar-Rahman ar-Rahim. It's nice to be in Jubail, the beautiful city. Yesterday we have a quick tour and we visited الهيئة الملكية, and it's really amazing city with the arrangement, with the beauty, with the people, with everything. And I borrow some أبيات الشعر فقلت فيها: لأنك قد كحلت عيني صباحا إليك أزف أشعاري صباحا، رأيتك يا ابنة البحار الطوامي عروسا تحمل النغمة وشاحة، كأنك يا هبة الخليج ليلى تعطرت بالورد والجوري فاحة، لما بدت فكل الخليقة قيس رآها ثم جن بها وساحة. We will start as yesterday. Thank you. Yesterday we start with Quran Kareem, and today we will start with Quran Kareem as well. صدق الله العظيم. ثم إنكم بعد ذلك لميتون. Everybody will die and we will be something like this. This skeleton recovered from a few kilometers south to where we are now in Tarut Island from Dareen, and it is from a lady who lived almost 200 years before Jesus Christ. It's a long time ago. Whenever I see these skeletons with the persistence of the bone, I always remember what Dr. Cook mentioned in the Lancet 60 years ago, when he said that the stability and immutability of these dry bones and their persistence for thousands of years after the soft tissue has turned to dust give us a false impression about bone during life. What's that false impression? Well, it's fixity after death, in sharp contrast with its ceaseless activity, with its continuous activity during life. And what's that continuous activity? Well, early on in life, we have the modeling. Apparently, we lost the here. Yeah, we have the modeling by which the bone increase in size, change the shape, and become stronger. Later on in life, the phenomenon change into remodeling. And this is described by John Hunter, and when he said, as the old bone removed, the new bone is formed, as you can see here. And this is by this process, we change our bone. Our bone change completely in 10 years. So you can swear that there is not a single cell in your bone nowadays will be there after 10 years. It's completely changed. Well, now I'll take you in a journey in the minute structure of the bone of this young lady to see what's going on during the growing period and before the menopause and after menopause. This is the minute structure of the bone, and you can see these flying cells coming to the trabeculae of the bone, and you can see these cells coming from the bone marrow, and they are prepared to remove the old bone, destroy it. So these cells, which we call the osteoclast, start to dig in the bone, remove the old fragile bone. Immediately, an army of bone builders come to the scene, the blue ones, and start to build up the bone, to patch the hole and fill the gap. And the equilibrium between the action of the bone eaters and bone builder give you the normal healthy bone that we enjoy during our life. Now we will leave this lady and go to her grandmother and see what's going on in the remodeling process in old age. As you can see here, and I'll jump here. Yeah, same thing. I'll take you in a journey to her bone, and notice how the difference between the bone of the young lady and the old lady, it's become like an old sponge. And the platelets which were there, now it's turned into cords and threads. Why is that? Because the cells which come from the bone marrow, they are more in number and they dig harder. And as you can see, when they start removing the bone builders, when they come, they cannot cope with the function of these strong cells. So there is kind of negative balance at each of these resorption holes, and in each of these resorption holes, the bone builders cannot batch the hole. اتسع الخرق على الراقع, huh? And the summation of this negative balance at each of these resorption sites give you the what we call the osteoporosis. That will give you the definition of osteoporosis. By the osteoporosis, there is decrease in the bone mass and there is deterioration in the bone structure. This and that lead to the fracture, to the fragility fracture. And this is why we concern about osteoporosis, because it causes fractures. And as you can see here, the normal bone on this side and the osteoporotic bone in that side. When you apply stress to the normal bone, you can see it keep its shape, while when you apply stress to the osteoporotic bone, it start to buckle and start to fracture. Same amount of stress. That give us the fracture. Fracture, as you can see here, fracture in the hip, a fracture in the vertebrae, and these fractures are serious fracture. They kill people, and those who survive, they have terrible lifestyle. And it is not any fracture. It is these fractures, we call them the fragility fracture. And by fragility fracture, it's a bone which breaks under condition that would not cause a normal bone to break. So exactly by definition, we define it, when there is, trauma that you fell down while you're walking, this is a fragility fracture. You sitting and you fell down, that's a fragility fracture. From a bed with less than a meter, also fragility fracture. When you miss 2 or 3 steps and you fracture, that's fragility fracture. But it's important here that we notice that skull fracture, the cervical spine fracture, fractures of the hand and feet and patella fractures are not osteoporotic fractures, so we don't consider them. Now, if I take you to this is very important to understand everything in osteoporosis, just to have few minutes about the pathogenesis of the disease, so you can understand how the medication work and what's the osteoporosis all about. This is the trabeculae of the bone, spongy bone, and in between of these trabeculae we have what? Where's Dr. Somali? We have the bone marrow. He used to be our resident. Okay, we have the bone marrow, and now the bone. I'll take a picture, magnified picture of this bone marrow of this area, and examine it. What happened here? Here we have the. Sorry, is it? Yeah, this is the bone marrow here, and this is the bone trabeculum. And here we have the osteoblasts, which are blue in color. Now, the cells from the bone marrow carry in their surface a receptor which called rank receptor. This, whenever there is a receptor, we should have a trigger for that receptor. What's the trigger for that receptor? It happened to be a molecule that comes from the osteoblast. We call it rank ligand for the rank. And these, molecules, whenever they come in contact with the receptors, they invite the pre-osteoclast from the bone marrow, the macrophage from the bone marrow to the bone. Not only that, the rank-rankle interaction again lead to maturation of these pre-osteoclasts, a fusion of these osteoclasts. Not only that, the function of osteoclasts when they eat bone, also it's completely dependent on the rank-rankle interaction. Now, if this process continue forever, what happened to your bone? All the time you have rank-rankle osteoclast eating your bone, it will vanish, it will disappear, and God will not accept that. So he provides us with what? With a natural inhibitor for this process. And that natural inhibitor, it comes from the osteoblast, and it is known as osteoprotegerin. And this osteoprotegerin, it will block the rank-rankle interaction when it comes to this rankle and prevent them from going to the pre-osteoclast and osteoclast and stop their action. This is why I always say it's like a wall or a fence that protect a barrier between the rank and the rankle. And this is what happened during the lives of childbearing in the ladies. The estrogen, what's the function of estrogen? Why it protects the bone? Because it induces more of this osteoprotegerin. It builds up the bone between the rancle and the rank. This is why it deprives the osteoclast from their fuel, so it causes osteoclast deprivation. Now, when the estrogen disappears or decreases after the menopause, what happened to the osteoprotegerin will go away, the fence will be gone, and instead of deprivation of the osteoclast, there will be activation. They will be released from, these rankle released from the inhibitory effect of the osteoprotegerin. And that will bring us to the function of the various medication that we use. And we know that the hormone replacement therapy and the SERMs, which are the selective estrogen receptor modulators, they work in osteoblast to produce osteoprotegerin, as we said. How about the bisphosphonates there in orange? Bisphosphonates, they go to these resorption sites, which we discussed, and they will be taken by the osteoclast, and they poison the osteoclast. They attenuate the osteoclast. Sometimes they kill the osteoclast. This is why the osteoblast will have the upper hand, and this is the function of bisphosphonate. How about denosumab? Denosumab, it's like a molecule which looks like osteoprotegerin that will also, we will give it to the patient. It will block the rankle. It will build up defense, as we said before. Now, if we go to the anabolic, which is the intermittent PTH, it has a completely different action. It works in the osteoblast to increase the function of osteoblast and to build up new bone. And that will bring us to the medications that we have in osteoporosis. We have a medication that tells the osteoclast slow down, and medication that tells the osteoblast please work more. Those who would work on the osteoclast, slowing down the osteoclast, we call them the anti-resorptive medications. And these anti-resorptive medications, a few years ago, we used to have all these medications. As we progress, we should have more medication. Is that right? Well, as a matter of fact, now, as we progress in medicine, we have less medication and anti-resorptives because some of these medications prove to be either not cost-effective or the risk-benefit ratio was not favorable. This is why we lost some of these medications and we don't use them. The medication we have in the Saudi market, they are only now 3 medications. We have from the bisphosphonate, we have the alendronate, and we have the zoledronic acid. And we have the denosumab. Now, if we go to the bone builders, and it is the only one available for us in the Saudi market, is teriparatide. A new advancement in osteoporosis field, we have more medication. We have the abaloparatide and we have the romosozumab. And these medication, we don't have them yet in the Saudi market. So our discussion will be just for practical use. Discuss the medication that we have in our market. Now, what's the effect of this medication on the bone? The protection for the bone. As we said, the main thing in osteoporosis is the clinical endpoint is fracture. How this medication doing in protecting bone from fracture? Well, all these medication will protect the bone, will give you protection against vertebral fracture. As you can see here in the orange, for example, this is the zoledronic acid. After 1 year, you have 60% decrease in relative risk of fracture. After 3 years, you have almost 70%. And you can see all these medication, there is significant decrease in the vertebral fracture by using them. And that's shown also in meta-analysis from Murad and Mayo Clinic. As you can see here, these eye medication did not cross the line. That means they protect against vertebral fracture, while the other calcium, vitamin D, etc., it will not protect against vertebral fracture. If we go to the non-vertebral fracture, again, the medications that we have in our market, all of them, teriparatide, zoledronate, denosumab, and alendronate, will protect against against non-vertebral fracture. Now, a few words about bisphosphonates, which are practical points. Again, we have oral bisphosphonate alendronate. We have IV bisphosphonate, which is the zoledronic acid or Aclasta. These medications are broad-spectrum anti-osteoporosis medication. You can use them for postmenopausal ladies, men with osteoporosis, steroid-induced osteoporosis, disuse osteoporosis. So they are good medication for osteoporosis. The things about them, you cannot use them while the patient is hypocalcemic. So it's practical point. You have to check the calcium before starting the medication. And also, you cannot use them with people who are in chronic kidney disease. The cut-off line for the creatinine clearance is 35. So if your patient have creatinine clearance below 35, it's not allowed to use the bisphosphonate. And also, the other thing about the concerns in the bisphosphonate, oral bisphosphonate, when you have upper GI problems, when you have problem with reflux, when you have problem with esophageal varices, Zollinger-Ellison syndrome, all these things, it is the enemy of the esophagus, the oral bisphosphonates. So be careful not to use them with these patients. Also, there is with the IV bisphosphonates, especially after the first dose, there is acute face reaction, which sometimes become intractable. And for the long use of bisphosphonate, we worried about what we call the osteonecrosis of the jaw and the spontaneous subtrochanteric fracture of the hip. So the red flags here, we have as we mentioned, upper GI problem, renal impairment, hypocalcemia. Don't forget this. Check your patient for calcium and creatinine clearance. If the patient had GI symptoms, send him to Dr. Hassam Junaid. Let him clear it, give you clearance before. This is what I usually do. Just send it to Dr. Junaid and he will clear them for me before I start them with the bisphosphonate. And very important to follow the protocol of the oral bisphosphonate. You should take the bisphosphonate an empty stomach in the morning because the absorption is very bad, the absorption of bisphosphonate. It will be only 6 per 1,000, not 6%, no, per 1,000 will be absorbed. This is why if you take something with bisphosphonate, it won't be absorbed and the patient will not get benefit. Also, it should be, you should take it with a lot of water because as we said, it's the enemy of the esophagus. So you have to push the medicine down. And you should also stay in upright position for half an hour to prevent the drug from going back to the esophagus. And you should follow this protocol really carefully. Now, a few words about the long-term side effects of bisphosphonate. We know the ONJ, the osteonecrosis of the jaw, and the subtrochanteric fracture. They are very, very rare. And it is almost 1 per 100,000 patient a year for the osteonecrosis of the jaw. And it is for the atypical fracture, it's 2 per 100,000. So this should not prevent you from using the medication. They are good medications. And we say always, this had been calculated, for every 100 hip fracture prevented, there is a risk of 1 atypical femoral fracture. So the general thing that we use this medication for 3 to 5 years, then we reevaluate our patient. Then we come to the denosumab. Denosumab, as we mentioned, it is, again, good drug that will, and it's anti-resorptive drug that will put a barrier or a wall from the rank-rankle interaction, and this is why it protects our bone. And it works on the spine, in hip, in vertebral, non-vertebral fracture. And it's the good thing about it, it will be given subcutaneously every 6 months. That's good. And it is attractive option for those with chronic kidney disease. It will not go to the kidney. So those with chronic kidney disease, if you decide to use something for them, then your option will be denosumab. So it is a good option for those who cannot tolerate the oral bisphosphonate, have some, contraindication for IV bisphosphonate, those with renal impairment, and still the drug is relatively new, so we don't know a lot about the long-term safety profile. It can cause also osteonecrosis of the jaw and atypical fracture of the hip. It's less than bisphosphonate, but the concern is also there. Also, there is important thing that it might affect the immunity because it works on the rank-rankle osteoprotegerin system, and that system is not only on the osteoclast, it's on the macrophage and other parts of the body. So it is, something to watch for, especially with those who are immunocompromised. You have to, again, you have to check your calcium and you don't give it for those who are hypocalcemic. What I usually do, I bring the patient same day and check the calcium in the morning, let him wait 1 or 2 hours, make sure that his calcium level is okay, then give him the injection because it's very strong hypocalcemic effect sometimes. So we have to check the calcium and we have to avoid it in those with immunocompromised patient. Now we come to the teriparatide, which is the anabolic. It is intermittent teriparatide. It's daily injection for 18 to 24 months. It rebuilds up the bone. So again, it was in vertebral, non-vertebral fracture. And it's indicated for those with severe osteoporosis, especially those who continue to fracture in spite of using the bisphosphonate. It's not for general use for the patient with osteoporosis. It's an expensive drug, so it has its own indication. Again, you don't give it to a patient with renal impairment. Creatinine clearance should be above 35, and it can be used for those with steroid-induced osteoporosis as well. So the red flag, again, the renal impairment, patient with urolithiasis and hypercalcemia, not hypocalcemia. This is PTH. And PTH, the hormone, it mobilizes calcium from the bone to the blood. So those with hypercalcemia, with high PTH, you should not use the drug. So 2019 menu that approved by the Saudi FDA. Again, bisphosphonate, it's almost always an option, in particular for elderly. It's considered the first-line treatment. Then denosumab for those who cannot tolerate bisphosphonate or those with chronic kidney disease, and teriparatide for high-risk patients with severe osteoporosis. Now, which drug to use? As we mentioned, the efficacy is important. You should know the efficacy of your drug. You should know the indications, contraindications, comorbidities of the patient. We have a patient that came to us with a bleeding esophageal varices after the first tablet of Fosamax, and nobody checked for esophageal varices. Then also the convenience of the regime for the patient. Some patients don't like the daily injection. Some patients don't like the weekly dose with, stay upside in the standing position for half an hour, etc. The cost is very important. Now we have with the generic alendronate, the treatment of bisphosphonate become very, cheap. And this is why we like to give it to the patient who needs it, and the patient preference. Now, who should be tested for osteoporosis, whom we offer a BMD? Well, it depends on what guidelines you read and what guidelines you follow. The North American Osteoporosis Foundation and the American Academy for Family Physician, they said about whenever this strategy is kind of screening strategy, and it's different from the European approach, which is case finding strategy. But this seems to be reasonable. So ladies after the age of 65 and men after the age of 70, we offer them the BMD. Younger than that, we offer them BMD if they have risk factors, as we will discuss later on. Then adults with a fracture, fragility fracture, not any fracture, also we will offer them BMD. Those with taking steroid or rheumatoid arthritis will offer them BMD. Now, you did your BMD, whom you will treat? That's a very important question. Well, to address this question, we have to ask ourselves another question. Why are we treating osteoporosis? I mentioned that before. Why are we treating osteoporosis? No, we'll take some time from Dr. Jimmy. Okay, he mentioned in 2 minutes. Okay. Why are we treating osteoporosis? Well, it's nice to have the BMD better and to improve the bone markers, etc. But the main thing, we want to prevent a fracture. As you heard this statement yesterday, we are not treating osteoporosis. We need to treat patients with osteoporosis. We need to prevent a fracture. And we have here, if we look at the osteoporosis, we know by a T-score minus 2.5 and below, this is osteoporosis. Now we have body of evidence that the raised probability, the raised risk of fracture in these patients below minus 2.5 will be improved by using the medication. But as I said, the elevated risk, whom are at the elevated risk, will that differ from one country to another country, as we mentioned? In areas like, for example, Austria, Switzerland, they have very high probability of fracture. In areas like Kuwait and Lebanon and US black people, they have very low probability of fracture. So you have to find out what's your probability of fracture in your country. Then the important question, when we come to those who are osteopenic, shall we give them medication or not? Let's look at these data trying to answer this question. We want to answer, do they fracture or not? Those with a T-score between -1 and -2.5. Well, look at this data from the large NORA study, we call it. And here we're looking at the fracture rate on this side of the curve. And this is this is the line, the osteoporosis. These are osteoporosis, this is osteopenia, and this is normal, and this is we're looking at the rate. Now, if you look at the rate, Whenever you go into osteoporosis, the rate of a fracture will increase. Now, I want you to look into the other side of the curve and look at the actual number of fracture, the absolute number of fracture. And we will see that the actual number, this is the actual number of fracture. What happens? Those who are designated as osteopenia, the number of fracture more than osteoporosis. Why is that? Because we have less women in this category. The death rate outstrips the fracture rate, and we have less women. We have less fracture. So we don't want to forget this number of fracture. So how we go with those osteopenic patients who will fracture? Well, we look into the risk factor, and the risk factor this is the effect of age on fracture. And we're looking here on this side, the age, and looking here at the T-score. And if you take a lady at the age of 70 and the T-score of minus 1.5, her probability of fracture almost 15. Now, if you take a lady who is at the age of 50 and the T-score minus 2.5, what's her probability of fracture? It's only 11. So what's that tell you? That tell you that the T-score impact on fracture is modulated by age. This is why those who are premenopausal, we don't offer them a treatment because the age is working with them. So the T-score minus 2.5, it's only one factor. So those who are elderly, the age start to work against them. It is not a knee-jerk reflex that minus 2.5, irrespective to the age, give them medication. No, it doesn't work like this. So this is one factor, the age. Another factor, if you have previous fracture, this will lead to another fracture. It's not only in this cartoon, but again, also and these studies show you that whenever you have fracture, your probability of another fracture will increase 2, 3, even 7 folds according to what you read. And this is, we come to this, that osteoporosis, guys, is multifactorial disease. It is not only BMD. There are another factors, and always I use this analogy that like other multifactorial diseases, or coronary artery disease, for example, the surrogate marker, the risk marker factor is hypercholesterolemia, and the clinical outcome is myocardial infarction. Not everybody with hypercholesterolemia will have myocardial infarction. And not everybody with myocardial infarction should have hypercholesterolemia. Same thing in osteoporosis. Low BMD, not everybody with minus 3, T-score minus 3 will fracture. And those with fragility fracture, they might be osteopenic or normal BMD because there are another factors working. What are these other factors? As we mentioned, prior fracture, age, family history of fracture, smoking, steroid, alcohol, rheumatoid arthritis, BMD, and age. All these factors play an independent role in predicting the fracture. How to evaluate your patient? This is what we call the fracture risk assessment tool, and I encourage you to start using it. It's very important. We in the Saudi Osteoporosis Society, we will, within a few months, will have our own tool and we will distribute it to you. What you do, you just put FRAX in Google and you have this picture. And you go to the FRAX to calculation like this, calculation tool, and you have all these areas of the world drop-down window. You go to the Middle East and North and Africa, and you have these countries. We don't have Saudi Arabia yet. Hopefully within a few months, we're working on that. We'll have Saudi Arabia there, and you choose, and you have this drop-down window. These are the risk factors. You fill them up. And after the end, you put your T-score. The beautiful thing about this, if you don't have BMD, you are in a place where no BMD. Well, you don't treat osteoporosis? No, we treat osteoporosis. Just forget about the T-score. Don't put it. And this will calculate for you the probability of a fracture for major fracture and for hip fracture over the 10 years. And for this patient, if she is Italian, her probability of fracture 11% and 2.2% as for major fracture and hip fracture. Same profile. A lady who is US Caucasian, her major fracture probability 25 and hip fracture probability 2.2. Now, what to do with this figure? We have to determine, according to our country, what's the cut-off line for a treating patient. In US, months of the country, they consider 20 and 3, 20 for major fracture and 3 for hip fracture. So we come to the last slides here. How to go with all these scenarios? Well, you screen your patient and you did your BMD lady who is at the age of 65 or 7 man above the, you did your DEXA. If they are at minus 2.5 and below, then we will offer them treatment. If they are between -1 and -2.5, what we will do, we'll ask ourselves question, do they fracture? And we will go to the fracs and frax them, as we mentioned. And if they are 3 or above percent for hip fracture, 20% or above for major fracture, then we will offer them treatment. If they are not, we will ask them for lifestyle modification, calcium, vitamin D, and recheck them again periodically. So, how long we treat? We need to know the side effects of the drugs. We need to know when we stop the drug, what the consequences. And we know that if we stop the drugs like, bisphosphonate, the effect will continue because bisphosphonate will go to the bone, stay in the bone for a long time, go from the bone to circulation and go back to the bone. So the effect will continue, and we recommend that for bisphosphonate, for zoledronic acid, to use 3 to 4 injections. It's yearly injection. For bisphosphonate, for Fosamax, to use it for 5 years. Then you give drug holiday, and you bring the patient and evaluate them again after a year. So some medication, for example, the denosumab, if you stop it, it will rebound. It's not will go back to the 0. No, it will rebound. And patient, after stopping denosumab, start they fracture their vertebrae. This is why when you stop denosumab, you should give the patient strong bisphosphonate like zoledronate or alendronate. Lose benefit when you stop serum and the hormone replacement therapy. So to summarize, what is osteoporosis? It decreases bone strength and predisposed to increase risk fracture. Why should we care? Because it's common, it's significant. There is morbidity and mortality with it. Whom to test? DEXA for all women above the age of 65 and higher risk, and men above the age 70. Frax is a useful tool. Whom to treat? That's individualized decision. How to treat? We have approved agents which are safe, and effective treatment decisions must be individualized. And this will be my last thing. This is from, I mean, what I call the osteoporosis continuum. Grandmother and mother and the daughter, they going into osteoporosis. When I asked the grandmother with this stooped back about her back, she said my back when I was young was straight like حرف الألف. Now it's like this, and this reminds me about قول الشاعر وعهدي بالصبا زمنا وقدي القد أي الطول. حكى ألف ابن مقلة في انتصاب ابن مقلة، خطاط كان يرسم الألف باستقامة عجيبة. وصرت الآن منحنيا كأني أبحث في التراب على شبابي. When I asked the mother about her approach, she said, well, doctor, with all Dr. Junaid medication and antihypertensive, anti-diabetes, you, بإذن الله, added years to our life, but not life to the years. What kind of life my mother is living? She cannot see the sky. And when I asked this lady about her philosophic approach, she said, my grandmother had become full with wisdom. This is why her back cannot hold it anymore. This is why she stooped forward. And again, that reminds you قول الشاعر ملء السنابل تنحني بتواضع والفارغات رؤوسهن شوامخ. المتكبر دائما أجوف والعالم الحقيقي متواضع. شكرا لكم.
Thank you, Dr. Shakir, for your 50-minute lectures. He just mentioned 30.
Of the medications. We're going to start with the risk factors and the screening, prevention, and some treatment options, and we'll go over some of the guidelines. Imagine if, like Gilgamesh from the old Greek legends, if he meets Shakespeare, he will tell him, eat, smoke, and be heavy, for cardiovascular death will come when it will come. And this is, I hear this statement from some of my patients actually. So, I mean, yeah, doctor, whatever you say, khalas, I mean, we will die whenever we are going to die, which is true. However, I mean, always we are asked to take prevention, right? عقلها وتوكل. We have to take, ناخذ بالأسباب. We have to take really into consideration our health, and our health is amana, which is, I mean, amana we have to take care of. So we all know about the cardiovascular risk factors, which one of them is obviously dyslipidemia, and among hypertension, tobacco smoking, diabetes, obesity, and some non-modifiable risk factors which lead to atherosclerosis and eventually to cardiovascular death. Dyslipidemia is the most common actually risk factors which is modifiable, and this is in North African and the Middle East study. A study showed that dyslipidemia is the highest one. And this is also in Saudi Arabia, part of the study, 69% is the prevalence of dyslipidemia, which is very high among the adult population. So when to do screening? Actually, as we yesterday saw by Dr. Basudan lecture about prevention, in the United States Preventive Service Task Force, they are recommending the age of 35 for male and age of 40 for women or postmenopausal. And earlier if the patient is from some ethnicity like South Asian. However, the American College of Cardiology recently, they are recommending to check at the age of 20 for baseline of cholesterol actually, especially for those who are at higher risk. And you can screen at any age if the patient has higher risks or have one of these like really risk factors, like if they already have like MI, definitely at any age you have to screen abdominal aortic aneurysm, diabetes, hypertension, smoking, okay, family history, chronic kidney disease, obesity, HIV infection, because it's also one of the risk factors for atherosclerosis, inflammatory diseases like rheumatoid arthritis. Any one of these actually make you check for cholesterol at younger age. Now, what are the recommendations? In most of my slides, I will actually take the recommendations from the recent one from the European Society of Cardiology and the European Atherosclerosis Society 2019 guidelines regarding the checking and treatment. So they are recommending to check all the lipid profile, including total cholesterol, HDL, LDL, and triglyceride. But LDL is still the primary lipid analysis, which is used for screening, diagnosis, and management. Non-HDL has some uses, and ApoB, if available, is also similar to LDL, but it is expensive. And some other measurements which are not available everywhere, like the lipoprotein A measurement, can be useful in patients with very high risk or strong family history of familial hypercholesterolemia. Now, why do we care about LDL? Because studies showed that the lower the LDL, the lower the risk of cardiovascular problems. And this is, I mean, even now they are going even lower, especially in the European guidelines, which are more aggressive. Some patients, when you risk stratify them, and depending on like lipid profile and other risk factors, you still like are not sure, and you need to do some other tests, including like the calcium scoring, which is CT cardiac without contrast, this one for the calcium scoring. And this calcium scoring can help you in guiding actually the treatment options, especially if the patient are hesitant. They are not like very high risk or high risk, but they are intermediate risk, and they are hesitant to start statin, or they have side effects from statin, and you are not sure what to advise them. They are not like obviously very high risk. Then in those patients, you might want to add another like tool to help you in deciding about the treatments. Now, you have a patient with dyslipidemia and you decide to treat them. What to treat? As we mentioned yesterday, for hypertension and for every chronic disease which can be like dealt with by non-pharmacological treatment, always you start with lifestyle. And lifestyle, we mean here, of course, diet, exercise, and weight control. Since 2015, actually, there was less and less emphasis about cholesterol from diet. Cholesterol, not fat in general, about cholesterol from diet. There was more emphasis on refined sugar. So you have to really consume less refined sugar, especially like the carbohydrated beverages and other like refined sugars like the white sugar. And the total cholesterol is not like a big issue in the diet because it's not contributing much to the total cholesterol level in the blood, okay? However, still, of course, you have to consume less saturated fat and replace it with monounsaturated fat and polyunsaturated fat. You have to consume more vegetables, fruits, nuts, whole grains, and fish. They are recommended. And also you have to minimize the processed meats and refined carbohydrates, as we mentioned, and the sweetened beverages, cola, Pepsi, or whatever, and the other like 7-Ups. All of these are really harmful. And the most harmful one is the trans fats also in the diets. Exercise also on 50 minutes per week, and weight loss, as we mentioned. Most of our patients, as we mentioned yesterday about the hypertension, will not decrease their cholesterol to the levels which are really warranted by only lifestyle, which is still you have to do it anyway, but you probably need to start treatment. And the treatment here actually is the statins, as you know. This is the mainstay of treatment, which is the HMGO coenzyme inhibitors. And the statins are used for both primary and secondary prevention, and this is based on evidence. For primary prevention, the evidence is less than secondary prevention. This is why you have to think twice before starting the patient on statin for primary prevention. But it is proven by many studies, including like this Jupiter, ASCOT, all like known studies which resulted in clinical outcome, not only in decreasing the LDL as a number, but also decreasing the events, the cardiovascular events, as we see here in the far end of this slide. And there is also a relatively recent study in 2016, the HOPE-3 trial, which has two arms, one for prevention in hypertension and the second one for dyslipidemia. It was negative for the hypertension arm, however, it was positive for the dyslipidemia arm, and it showed that if you treat your patients with this medication, rosuvastatin, in intermediate risk patients who don't have cardiovascular, so this is for primary prevention, it will decrease actually the risk of the cardiovascular events. For secondary prevention, which means if the patient already have MI or cardiovascular events of any type, then you have to give them, of course, statins for secondary prevention, and this is well proven in many studies also to decrease the events, the second events. Now, everything is at a price, especially like in medicine, right? So statins, we all know that they have some side effects. Actually, some of them, there have been a lot of many like reported or like stated like side effects like those who are not supported by evidence. But the ones which are really supported by evidence as a side effects are the myopathy, the hepatic enzyme elevation, and the new onset diabetes. And myopathy here actually is more common among patients with low vitamin D. And here, I have in common with Dr. Shaker. Dr. Shaker is referring patients to me. I might refer some patients to you too. So vitamin studies show that patients who have low vitamin D, if you and they get some muscle pain when they are put on statins, they might do better if you replace the vitamin D. So look for low vitamin D in your patients who are on statins and complaining of muscle pain, because it might be contributing factor and they improve. And how often we check the liver enzymes to check for the side effects? Actually, you have to check liver enzymes before treatment, and then once 8 to 12 weeks after treatment with a statin, and then you don't need to check it routinely. So you don't need to check it every 3 months or every 6 months. I'm talking about the liver enzymes, because if it's gonna go up, most likely it will go up in the beginning, okay? However, if it's clinically indicated, if the patients are complaining of some symptoms which might refer to clinical problem with the liver, then definitely you have to check it. And you don't stop treatment just with a slight elevation of liver enzymes. You stop it, of course, if it's more than 3 times normal, okay? And then you might restart at lower dose. But if it's like less than 3 times of normal, you can continue therapy and recheck it in a short time after like 4 weeks, and then you decide. What about the muscle side effects? The muscle side effects also, I mean, you can't, of course, if it's like severe, like rhabdomyolysis, this is emergency, and the patient needs IV fluid and admission and everything, then definitely here you have to stop and look for the causes, including statins or other causes. But if it's like less than 4 times upper normal for the CK elevation, then you have to stop it anyway. And then you give like a washout for 2 to 4 weeks without statins and see whether the symptoms go away or the CK goes back to normal, then yes, it is the statin. If it doesn't go away within 2 to 4 weeks, then probably you have to look for other reason, okay? Before like considering stopping statin and replacing it or starting another one. And one consideration is if you want to restart your medications after the CK goes back, is to give the alternate approach, or the once weekly or like twice weekly of the statin. That will decrease the risk of elevation of the CK. So we mentioned several strategies, including like maybe also giving another medication if indicated, and vitamin D, vitamin E, and all those are well studied. Now, statin is not the only medication which is used in lipid disorders. This is old medication, niacin. It's very effective actually in improving the HDL. It will increase the HDL, decrease the triglyceride, improve the LDL. However, it's not well studied, and it has a lot of side effects like flushing and other side effects. Flushing can decrease if you give aspirin concomitantly. However, this medication is not studied widely for the clinical outcomes, but it is effective in lowering the bile acid sequestrants. We'll see that you can use it if the statin is contraindicated, like in pregnancy, for example. And it is effective in lowering LDL. However, it's like too many pills and also GI side effects. Ezetrol now is the another like good addition to the medications for lipid treatment. And it showed clinical favorable outcome actually in this study, which is called Improve It trial, which showed like improvement in all, reduction in all like major cardiovascular events. The new medications, probably you have heard about. The Saudi FDA recently just studied this outcome of the Odyssey trial, which is called the PCSK9 inhibitors. Those are new medications, very expensive. They are used sub-Q. twice, every 2 weeks or every like 4 weeks, depending on the medications. They have like really limited indications, but they are a very good addition because they proved good clinical outcome. So now, what are the targets and when to treat? We'll go over some of the guidelines. First, as we mentioned, for the hypertension, there is no one size fits all, okay? You have to risk stratify your patient. You have to look at your patient, look at the other risk factors that your patient have, and decide whether the patient is very high risk or intermediate risk or low risk. And you can use any scoring system. Those are available in the now Google Play and in the iPhone. Or you can Google it. There is the SCORE, call it SCORE system, which is the European system, and there is the ASCVD scoring system, which is the American system. So you can, excuse me, you can use any one of them. Here, the European, since it's the latest guidelines, they classify their patients to very high risk, intermediate risk, and low risk. The very high risk are the ones who are already having atherosclerotic disease, those who had MI before, or stroke, or like acute coronary syndrome before, or those who have like diabetes with end organ damage and with at least 3 major risk factors. So those are considered very high risk. Or those with severe chronic kidney disease, they are already considered very high risk. Or those who have very high score system, which is the risk stratification scoring system, more than 10% risk of 10-year risk. High-risk patients are those with markedly elevated single risk factor, in particular like high LDL or blood pressure high or other risk factors, or patients with diabetes without target organ damage, but they have longer duration of diabetes. Those are considered high risk. Or those with moderate chronic kidney disease, okay? Or if the score system is between 5 to 10%. The moderate risk are those who score between 1 to 5% in the score system, okay? And the low risk are those who are low risk, less than 1%. You remember the table yesterday? You look at the number of the LDL when you decide treatment and the the total risk, cardiovascular risk, based on the score system in the European guidelines. And then you decide how quick you have to give medications after lifestyle changes. So if the patient is low risk, then probably you will not need to treat before the LDL is 190 milligram per deciliter. But you consider it if it's lower, and you always recommend lifestyle, okay? If the patient is very high risk, then you have to aim very low. You have to aim less than 70 milligram, and even in the recent guidelines, less than 55 milligram. I don't know which units you use. Is it the milligram or the millimole here in your labs? Millimole per liter or milligram? Millimole? So it's less than 1.4 now in the European guidelines, which is very like really aggressive, reaching these targets in those patients who are very high risk, considered as very high risk. And because, as I mentioned, the lower the better, as shown by the study. And for secondary prevention, for those who already had really an event, then you have also to start treatment as early as possible to aim at LDL less than 1.4 millimole per liter. And also you aim at 50% reduction from baseline. And this is both for American and European guidelines, they aim at this. So 50% from the baseline and to a level of less than 1.4 for very high risk patients. Now, this summarizes the recommendations for the levels that you aim at. I find the European very aggressive, but are the most updated and based on evidence, actually. So if the patient is, as we mentioned earlier, is low risk group, then you aim at 3 millimole and low. If the patient is moderate risk, you aim at 2.6 millimole and lower. If the patient is high risk, then you aim at 50% reduction and to be less than 1.8, which means 70 milligram per deciliter. And if the patient is already very high risk, then you aim at 1.4 millimole or less than 55 milligram per deciliter. You might find this very aggressive. Now, how effective are the treatment in lowering the LDL, okay? Statin alone they are like classified into moderate intensity and high intensity. The low intensity are not really now used or recommended like anymore. The moderate intensity will lower the LDL by 30%, the high intensity by 50%. If you add ezetimibe, it will become to 65%, and then if you add PCSK9 inhibitors, 75%. If you have 3 medications, PCSK9 inhibitor plus statin and ezetimibe, it will lower it by 85%. Okay. So you again check your cardiovascular, the cardiovascular risk of your patient, and if there is indication for treatment, the first line of treatment after lifestyle is statin. If this is not reaching the target, you add ezetimibe. If this is not reaching the target, you add the third new medication, which is expensive, which is the PCSK9, especially in very high risk patients, especially for secondary prevention. Okay. Now, what about triglyceridemia? We all know that triglyceridemia is not as important as LDL, and we care about triglyceridemia, especially if it's very, very high, then there is a risk of pancreatitis and other like really complications. However, for the heart, it is a risk factor, but it's less important than other risk factors. So now the European guidelines are recommending really to start. Before, we used to recommend like fibrates because it's more effective in lowering the triglyceride. No, now it's recommended to start statin treatment for even triglyceridemia because you want to hit 2 birds by 1 stone. Okay, you will lower the LDL, improve the outcome, and also lower the triglyceride. So if it's more than 200 milligram and your LDL is not reaching the target, then you give statin. They are recommending also the omega-3 fatty acids actually, but the evidence is weak. The evidence is weak for this one, not very weak actually, 2A, but they are mentioning this in the recommendation if you cannot reach your targets by reaching the statins, because there were several studies lately about the omega-3, some of them in favor, some of them are not in favor of this. What about women? Women the same as men, however, you have to remember always. You know, remember I mentioned yesterday about the ACE inhibitors and ARBs. You should not use them like unless the patient is on like really on contraception. Also, statins are teratogenic. You should not use them in women of childbearing age unless you make sure that they don't get pregnant. If they are planning to get pregnant or during pregnancy or during breastfeeding, you should not give statin. You should look for other alternatives. And if they have very high risk like familial hyperlipidemia, then probably you can give them bile acid sequestrants or LDL apheresis or other methods. What about elderly patients who are more than 65? You still use the same, go for the same guidelines. Unless the patient are more than 75 in this age group, there are not enough studies actually to recommend anything. However, the European guidelines are mentioning you have to like individualize treatment, and also for primary prevention, for secondary prevention, if the patient is already on statin and tolerating it well, then you continue giving it. The last 2 slides is about the American guidelines on the contrary to the European guidelines. The general concept is the same. However, here, like the American guidelines, they are recommending to give a statin for any diabetic patients if they are in the age of 40 to 75, and regardless of LDL, of course, level, okay? And this is the 2018, actually, guidelines. And you give moderate intensity statin, or if it's like the patient is high risk, then you give high intensity statin. And they risk stratify their patients according to their score, which is the ASCVD risk factor. And you consider the risk enhancers, like the ones that we mentioned before, the inflammatory diseases, the chronic kidney disease, and the other risk enhancer factors. Okay, and if the patient is already like very high risk here, they consider they call it, they don't call it very high risk, they call it high risk. Then you have to initiate, of course, statin to decrease it to more than 50%. So the goal is to decrease the LDL to more than 50% of the level, which is the baseline. And for the secondary prevention, of course, as I mentioned, also they are dividing patients for the age between 75 and above 75. Above 75, if the patient is already on statin and tolerating it well, you can continue on this medication. And they are mentioning about the new medications as the European guidelines. You add them to a statin if you are not reaching your target, especially in very high risk patients. So finally, you have to lower the LDL. You have to individualize therapy. You have to weigh up the benefits and the risks, and consider other factors contributing, other risk factors contributing. And the guidelines are always just guidelines, and you always start with lifestyle, as all the other chronic diseases. Thank you.
Thank you, Dr. Shakir. And Dr. Junaida. Dr. Shakir, please. We have like 15 minutes for question. So please, if you have any question about osteoporosis or hyperlipidemia. Yes.
Dr. Mahmoud.
Yes, assalamu alaikum. Thank you both for very informative lectures. Dr. Shekhar, I've actually got a question for you. Dr. Shekhar,
Yes.
Can you hear me? Good. Regarding bisphosphonates, there was a lot of discussions about drug holidays, how long it's safe to take them for. Can you give us a little bit of advice if we have patients with osteoporosis? Can we keep them on bisphosphonates indefinitely, or do we need to take a break?
Holiday from
Yeah.
bisphosphonates. Definitely, or you have to take holidays.
Well, the question about the drug holiday after bisphosphonate. Well, after you use bisphosphonate for 3 years in IV bisphosphonate, 5 years in oral bisphosphonate, you re-evaluate your patient. If the patient is still at high risk of fracture, that say T-score still below -2.5, then it's logic either to shift the patient to another medication still at high risk of fracture, or to continue with bisphosphonate another couple of years or 3 years. It's okay. Now, if you decide to give the patient the drug holiday, it's for 1 year, sometimes 2 years, but you have to bring your patient back in 1 to 2 years, re-evaluate the patient, make sure that the BMD is not dipping down again below -2.5. If the patient still in the osteopenic range, still, I mean, you have to check also vitamin D and calcium bone profile, all these things, then you just continue with no medication, just lifestyle and vitamin D and calcium. If the patient start to dip again, then it might be an indication to start denosumab or continue another 1 to 2 years, according to what kind of guidelines you follow. But I tend to stop at 5 years. If the patient needs more, then I shift to another medication.
Dr. Junaid, a lot of patients taking statin complain of muscle pain, and sometimes their CK level is moderately high. So how the best way to deal with that? Is it to stop the statin, decrease the dose, or especially for primary prevention? Or maybe if secondary prevention is mandatory to give the statin?
So I mentioned this in one of the slides. Thank you for the question, Roy. You can check the CK. You have to differentiate, of course, if it's like severe symptoms, rhabdomyolysis, definitely, of course, here, this is emergency, you have to admit. If the patient, like, CK level is like less than 4 times normal, you stop it for like 2 to 4 weeks as a washout and recheck it again. If the CK goes back to normal, then this is the statin. If it doesn't go back to normal within like 2 to 4 weeks, then it's something else. You have to look for the other reason. Let's say it's goes back to normal, it's the CK, and the symptoms goes away after you stop them. You have to look for other causes, contributing factors like vitamin D deficiency and others, and then you might reinitiate the statin if the patient, if there is really indication, you have to initiate the statin at lower dose or alternative statin, or you can give the alternate dose, which is like every other day or twice weekly. You are asking about primary prevention, then it is a good opportunity here to reconsider the indication and maybe add other like risk factors tools like the calcium scoring. For example, a patient who is 45 years old, doesn't have a lot of risk factors, consider like intermediate risk, let's say, and they are not convinced to restart the statin, then you add the calcium score. I would recommend this. If the calcium score is high, then yeah, this is an additional like really indication to convince them that you need to restart them and take the chance. If the calcium score is 0, then probably you can give them some time before restarting the statin again. Thank you.
Thank you. Dr. Shakir, for men and osteoporosis.
For what?
Men and osteoporosis are primary care. Do you recommend it to do the screening, the bone densimeter?
Again, the North American Foundation and the American Association for, I think, Family Physicians recommend to screen them after the age of 70. This is not the approach of the European guys. And European guys, they go with the clinical risk factor. If the patient has clinical risk factor and above a certain age, which is 60 or something, to do the BMD. So that depends, and also if the patient, for example, has a fragility fracture, you will do it. If the patient on steroid, rheumatoid, all these things, then you might consider doing it. In the Saudi Osteoporosis Society, we have different opinion. I tend to go with the 70 year, according as the people in North. Some of our colleagues in the society think that 65 years is more logic because our BMD is lower than the counterpart in the United States and in North in Europe by 5 to 11%, according to what you read. However, my point is, yes, our BMD is lower, but apparently our fracture rate is lower. The only study we have from Dr. Naeem, more than, I think, 20, 25 years ago, it showed that our hip fracture rate is not that high. So this is why I go a little bit higher at the age of 70.
Another question for osteoporosis. If I face sometimes patients in middle age, in their 40, 50 females, and most of them, they are overweight and obese. They ask for screening for osteoporosis.
For your voice.
Yeah. So the question is, when you face in your clinic a middle age in 40s, 50s, female, overweight, obese, and they ask us to screen them for osteoporosis by DEXA scan, what is the best way to reply for their question?
Well, in the past, we used to say that one of the indications for screening if the patient asks for it. And we changed that because, I mean, at the age of 30, 40, 50, before the menopause, as we said, the age is a protective factor. We screen and we do things because we want to see who will fracture and prevent fracture. Now, if you screen and you do it, and for the patient with age 40, then it comes with minus 2.6 or minus 2.7. Then what's your next step? You will start with bisphosphonate. You know that you will not start with bisphosphonate because, again, the age is protective. So we usually, our recommendation against the screen before the age of 60 or 65 for females, except if there is risk factors, those with steroid, those with fragility fracture, those with rheumatoid arthritis, those with sometimes with liver failure, and etc.
Thank you. So, thank you for both of you for the interested lecture. We're gonna move to our next session, and we having update in sport medicine. We have Dr. Ziad Al-Rayes, who's specialized in sport medicine. He get his family medicine, sport medicine from Canada. He's been working with us in family medicine and polyclinic for years. So please welcome Dr. Ziad.
السلام عليكم جميعا. المحاضرة هذه أو this session is going to be interactive. So I need you to be with me throughout the lecture. So ندخل بس عليها. وهذه أقدر أستخدمها قدام ورا صح؟ زيادة. So it's going to be questions and answers. I need you to be with me most of the time to go through the questions and answers. Our objective of this session is to evaluate the clinical sense in sport exercise medicine, to discuss the clinical scenarios and common musculoskeletal problems, to understand common musculoskeletal problems in athletes of all ages and different genders, and to summarize the findings at the end. There's a difference between physical activity and exercise. Physical activity is any body movement that produced by skeletal muscle that results in an expenditure of energy. Why I'm saying that? Because walking from one distance to another does not preclude an exercise. You will see and hear your patients, I am working here in the hospital, I walk from this side to this side, I'm exercising on a daily basis. No, exercise is defined as a physical activity that is planned or structured to involve repetitive body movement done by to improve or maintain one or more of the components of physical fitness. Walking is not considered as an exercise except if it is for 8 minutes or more. And moderate physical activity is considered in walking when the person cannot talk to his friend while he's walking. Describing these fine details to your patient is very, very important for them to go and exercise on a regular basis. First question or first case. A college soccer player has chronic history of biceps femoral strain. Of course, this is one of the thigh muscles, the posterior thigh muscle, and it's the commonest or one of the commonest injuries in soccer players. On the left side, stopping him from participating 3 games. The finals is in 4 weeks. What is the most effective time for stretching? Because these kind of injuries involve stretching. What do you think? During workout, why I'm emphasizing on these? Because your patients are going to ask you, what is the best time of stretching? Before, after, or during the exercise? So during workout, during warm-up, between workouts, or during cool-down? I want a show of hand. During a workout phase. During warm-up. Okay. Most of the people warm up. Between workouts and during cool-down. So the answer is, this is what happens in an exercise, is during the intensity of workout goes up during warm-up, and then during the endurance conditioning phase, it is maintained, and then it comes down during cool-down. So the best time is at the beginning of the cool-down period, where you have the strength and the stretch of the muscles are at its most. So your stretching is most effective at the cool-down. But there is no mistake if you will do it before the warm-up and at the cool-down. But if you're asking the most effective is during the cool-down period. Question number 2. Which one of the following deemed the worst prognostic indicator for a surgical repair? Inelastic poor quality tendon, scarring, muscle atrophy, fatty infiltrate, in the muscles. Why we are asking this question? Because the worst indicator means that if the patient goes for surgery, they will not have the best results. So you have to treat them or indicate surgery before they go into that. So inelastic poor quality tendon tissue, okay, 1. Scarring, 2 or 3. Muscle atrophy, okay, this is the most, and fatty infiltrate. So fatty infiltrate is the right answer because it is beyond scarring, beyond atrophy. It also, it has fat in it at this stage, okay? So it's very important to avoid the fatty infiltration once you have a rotator cuff injury or what have you. It means that you've prolonged the treatment and they've never received the proper. And in acute rotator cuff injury, it's very important to go for surgery within 3 weeks. The success rate in a traumatic acute rotator cuff injury, it's very important within the first 3 weeks to go for surgical repair because your rehabilitation, everything else will be perfect. Case number 3. I'm sure half of the people over here is suffering from this neck pain. So cervical disc herniation causes radiculopathy most commonly at which level? C2, C6, C7, T1, or C1? Okay, 2, nobody. 6, okay. 7, okay, half of the people. T1, okay, and C1. Okay, C1 of course is in the traumatic injuries rather than radiculopathy or neck pain. The answer actually is C7. It's the commonest place, and the commonest radiation is just below the shoulder blade. So if you have patients complaining of al-abhar or shoulder blade, it's usually a radiculopathy radiating from the neck. So the most important thing to understand is how to differentiate between shoulder pain and neck pain. This is very, very common in your family medicine practice on a day-to-day basis. But these are statistics that we need to understand when we diagnose patients and when we are looking up the x-rays. Case number 4. A 17-year-old soccer player with unexplained syncope. He denies cardiac or pulmonary history and thinks that he was just dehydrated. His cousin had an unexplained death at young age, and ECG was obtained, which is the most suggestive arrhythmic right ventricular cardiomyopathy. Which one is the worst indicator? Is it left ventricular hypertrophy, T-wave inversion, right axis deviation, deep Q waves, or ventricular pre-excitation? Why am I putting this case is to elaborate to all of our colleagues in family medicine is if you have a patient with cardiac history or cardiac death, ECG is a very important screening tool that you have to consider before letting them participate, especially if they have a syncopal attack. It's very rare. It's 1 in 100,000. But you don't want to attend the 1 in 100,000 death in front of you because it's very significant. And last year, when we had a conference in Dammam, they brought in the statistics in the eastern region. They had around 100 cases last year where they had death in the field in sport medicine. So the most important thing is the T-wave inversion, especially between V1 and V3. And in the US, it's essential to do an ECG for all athletes if they are participating or as part of their pre-participating exam into physical activities and exercise. So case number 5. Please stop me. If you have any question, we don't need to wait until the end. We could tackle the issue as we go along. Question number 5. Which one of the following recommendation would give a college-aged volleyball player with type 2 diabetes? Diabetes and exercise are very, very important, and more complex is when you have a patient on insulin who wants to exercise on a regular basis. And I have encountered patients who are marathon runners and diabetic, type 1 diabetics. So exercise is very important in the treatment of diabetes and should not stop them from exercising on a regular basis. So which one of these recommendations would you give? He should increase the pre-exercise insulin rate by 50% an hour before exercise. Or the biggest risk of hyperglycemia is during the high-intensity exercise. There is no difference in playing in hot or humid versus indoor, and increase the carbs after the match. So who's with A? Okay. B? Okay. C? Excellent. And D? Very good. It's very, very important for patients with diabetes, okay, to make sure that he does not go into hypoglycemia. More important than going into hyperglycemia, because it's more dangerous. So it's very important to adjust their carbohydrate intake. Every half an hour in the field, they should take some carbohydrates, between 30 and 50 grams. And the short-acting insulin should be reduced prior to the exercise. But if you're telling me which one is more important, it's the carbohydrates after the match or after the exercise, which is very, very important. And increase the carbs by 70 to 100 grams in case of high to moderate intensity exercise. What I'm trying to go into over here is every patient is different, and you need to go into their details of their exercise regimen. Having exercise in general is not specific enough for you to put down your recommendations. So it's very, very important to know exactly what the patient is doing and then accordingly adjust it. Of course, for a diabetic patient with type 2, you wouldn't recommend exercise if they have uncontrolled diabetes until you let them go for the BAR-Q questionnaire. So the BAR-Q, to make sure that they will not develop anything that is really significant during their physical activity event. Or if a patient is uncontrolled hypertension, the same thing. You might do some investigations, control their blood pressure, control their blood sugar before they start the physical activity later on. So sport medicine is not that I want you to get hurt. I just want you to be, I want to be there when you do. So case number 6, which of the following in an ill athlete should exclude them from practice? It's a very important question we are asked every day, especially in type A personalities. Athletes are type A personalities. They are perfectionists. They want to do their exercise every day. They don't want anything to stop them. So if they have cough, congestion, fever, sore throat, or headache. So who's with A? None. Who's with B? None. Who's with C? Everyone. I'm very happy to know that. Seriously, I'm very happy to know that. Because the only thing that should stop you from exercise if you have fever. Okay? Because with exercise, your immunity goes up and down at the end of the exercise. So it's very important for patients with fever to stop them from exercising. And if you have patients who was diagnosed with infectious mononucleosis, you should stop them from contact exercise for up to 3 weeks after the infectious mononucleosis, because they will have splenomegaly and they are at a risk of rupture. Case number 7. A patient presented for medical clearance for scuba diving. Which one of the following would disqualify him from participating? Asthma, pacemaker, history of spontaneous pneumothorax, sickle cell disease, and mitral valve prolapse. We put it in a different ways. Why? Because hypoxia hypoxia in scuba diving is very important to take into consideration. And you will, if you're a family physician, you will encounter such a patient on a regular basis, especially if you're in the eastern or western province, where scuba diving is more prevalent. Okay? So who says asthma? No one. Pacemaker? Few. History of spontaneous pneumothorax? Everybody. Absolutely right. Absolutely right. Because patients with spontaneous pneumothorax, even if they don't have it right now, okay, they might develop it later on. So you should stop them from going into, because they might rupture while they are down deep in the sea. Pacemaker, they make them under the skin and they could survive the water, so you don't have to worry about it. Mitral valve prolapse, there's no issues related to it with regards to scuba diving. The same as well with sickle cell disease. Case number 8. So 42 years old, labor worker, present with 6 months history of lateral elbow pain. Okay, I'm sure you see these patients on a regular basis. With no history of trauma, pain with grabbing, letting, and recently started dropping objects. There's no neurological symptoms, no locking or swelling. On examination, full range of motion, no arrhythmia, no ecchymosis or swelling. There is no tenderness. There is tenderness at the lateral epicondyle. There is pain with resisted middle finger extension. He was thought to have tennis elbow, but which one of the following should be considered? Tennis elbow is very, very common on our day-to-day practice in family medicine. As a family practitioner, 25% of the cases that will come in your door will be related to musculoskeletal medicine. So it's very, very important for you to know and diagnose these conditions. This is a very common condition we see and sometimes we overlook. Radiculopathy, chondromalacia, radiocapitellar chondromalacia, radial tunnel syndrome, posterior lateral rotator instability, pronator syndrome, distal radioulnar ligament rupture. So the purpose of this question is whenever you are dealing with tendinosis or tendinitis in musculoskeletal medicine, you have to put at the back of your mind other differential diagnoses that could be there, especially if the patient doesn't improve after 3 to 4 weeks of physical therapy or occupational therapy. So it's very, very important. I'll not go with the questionnaire because it's not an easy question. It's more of a difficult question, but you have to think about neurological causes and order neurological testing for such a patient to make sure that he does not have any nerve entrapment. Case number 9, 65-year-old male with a 5 months history of left groin pain, no injuries. Pain is worse in the morning, and he is gone from sitting to standing. He walks 45 minutes, 3 times a week, and golf 3 times a week, which he cut down in the last 3 months because of the pain. He feels like pulled groin, and 4 to 5 out of 10 is the pain. He tried ice, he tried heat, he tried glucosamine, ibuprofen with no improvement. He has history of hypertension and dyslipidemia. On examination, full range of motion. He had pain with internal rotation, and Fader test is negative. Fader is flexion, abduction, and external rotation. Your review of the X-ray tells the patient which one of the following. He has history of acetabular impingement. He needs MRI for labral tear. He has grade 3 AVN, or he has mild to moderate osteoarthritis, which should improve or should go away with physical therapy and exercise. So who says that he has acetabular impingement? Okay. Who says that he needs MRI for labral tear? Okay. Who says that he has AVN? Okay. and who says that he has mild to moderate osteoarthritis. Okay. So the answer over here is mainly for such a patient, you have to rule out acetabular impingement. So it's very important to take it into consideration. AVN is rarely seen without any kind of fall or injury, and if they are not taking any certain medications that will lead to avascular necrosis. And patients with mild to moderate osteoarthritis, they should improve with the use of non-steroidal anti-inflammatory drugs. So case number 10, 56 years old female presented to your clinic with pain in the middle finger with locking, but when she presses on it, the movement is not locking anymore. Now she noticed a snap with the locking, and she tried to overcome it with a history, with no history of injury. The treatment modality should include, what does she have first? Trigger finger, yes, absolutely. So what kind of treatment should you go for? Immobilization, steroid, watchful waiting, refer for surgery, all the above? Who says A, B, C, D, E? It's E. All the above is correct. You have to individualize your treatment for each patient. Some of them are not comfortable with injections or surgeries. So you tell them that this does not have any sequence for you in the future, and it's very important for them to have the reassurance. But you could go for surgery or injections. The rate of success of an injection is 20% in the first injection. It goes 40 to 60% on the second or third injection, and the rate of success of surgery is usually between 60 and 80%. Case number 11. Which of the following is true about femoral acetabular impingement? A preferred imaging is AP and lateral X-ray. MRI is not needed for symptomatic patients. If pain is not responding to conservative treatment, go for total hip replacement. Faber is the most sensitive exam maneuver. Initial treatment is no weight bearing. The femoral acetabular impingement is something that we see in the sport medicine with a rate that ranges between 5 and 10% with patients related to hip pain. And knowing how to treat it and diagnose it is very, very important. I highly encourage you to go and review that specifically, because it's one of the differential diagnoses of hip pain, okay? And it's more common in female than male, and mainly when they do internal rotation, they will have the pain there. So which one, who says the preferred imaging is AP and lateral X-ray? No one? MRI is not needed for symptomatic patients? Okay. If pain is not responding to conservative treatment, go for a total hip replacement. Okay. Faber is the most sensitive maneuver. Yes, it's Faber most sensitive maneuver. This is the clinical indicator that you should consider impingement syndrome. And the initial treatment should not include non-weight bearing. You should go for rehabilitation. It's flexion, abduction, external rotation. It's the combination of all these movements in the test itself. So it's very important to, if you write down Faber in Google or in YouTube, it will show you how to do that maneuver specifically. Case number 12, 20 years old female with acute ankle injury. She stepped on a rock while running and had an inversion. All these cases are common cases from the practice of sport medicine, and that's why it was chosen, and part of them are board examinations. So it's very important to have the knowledge and the understanding. So on examination, there's tenderness around the syndesmosis. I hope everybody knows the syndesmosis, which is the area between the tibia and the fibula in the ankle joint. The X-ray was done and showed widening of the medial with clear space and distal syndesmosis. Your management should be surgical referral, posterior splint, air boot cast, lace up ankle brace. So who says surgical referral? Who says posterior splint? Okay. Who says air boot cast? Okay. Who says lice up and ankle brace? The most important thing to understand about ankle injury is that if your auto ankle rule is negative, you should avoid doing X-ray, and you can be quite sure that the patient does not need any kind of intervention except rehabilitation and taking them off the exercise for at least 3 weeks, because the tendon takes, the muscle usually takes 10 days to 2 weeks. The tendon takes between 3 and 6 weeks. The ligament takes between 6 and 8 weeks for it to completely heal. The bone takes up to 12 weeks for it to completely heal. In this condition, what we are trying to emphasize is the widening of, in the X-ray, widening of the medial clear space and distal syndesmosis, which takes us to syndesmosis syndrome. Syndesmosis syndrome is very painful and could lead to very serious side effects for your patient. So in these conditions, surgical referral needs to be on an urgent basis to a foot and ankle surgeon to go and do the fixation, because they need to do it immediately rather than to wait and see and what have you. Okay? So when you're dealing with patients with ankle injury, most of them, you don't need to do any major intervention. But patients with syndesmosis injury, they have to go for surgical repair. Case number 13. In a 60-year-old athlete of, which one is the correct statement? We're taking you from pediatric to healthy adults to healthy elderlies. So training, although now they changed the middle age up to, or the youth is up to 65. Training sessions should be maintained at high intensity but shorter duration. VO2 max should remain the same, while loss of muscle due to loss of fiber number 1 or type 1. Accelerated loss of performance, more in males than females. Training sessions should be allowed shorter recovery between hard sessions. So I know I'm more going towards specific sport medicine issues, but I need you to think about these things when you are faced with your patients on a day-to-day basis. You will face 60 years old, 65 years old, and I had a 67-year-old lady who went into Everest and went to the summit of Everest. So you will have these type of patients on a day-to-day basis in your practice. The most important thing, regardless of the question, the most important thing is to follow the American College of Sport Medicine recommendation of exercising 5 times a week from 30 to 60 minutes on a regular basis from moderate to severe intensity, and 3 times a week with weight training, and include the balance training in these type of patients. So it's very, very important to take that into consideration. So the most important thing is training sessions should be allowed shorter recovery between hard sessions. So case number 14, 45-year-old female with 6 months history of right shoulder pain, right-handed, and no injury of the new activities. Pain is getting worse and limitation range of motion. Positive impingement signs. What is an impingement sign? So one of the impingement signs is when you go up like this and then, yes. And then if they feel pain, this is what we call impingement sign. They have different impingement signs that you could do. Just go up and ask the patient to go down like this. They will feel direct pain in their shoulder. That's with active movement, but it's better to do it passively, where you move the shoulder, okay? So you could hold the shoulder from here and then just internally rotate it. So what is your treatment? So what does the patient have? it's rotator cuff injury. Rotator cuff are more or less 4 muscles that are available or that are there in your shoulder. Supraspinatus, infraspinatus, subscapularis are the common. And teres minor, I've never seen any injury with teres minor. Okay? So if you have a patient with rotator cuff injury, what is your first treatment? PT, MRI, joint aspirations for crystal, refer them to orthopedics, sling and rest. So who says refer them to physical therapy? Okay. Who says do an MRI for that patient? Excellent. Nobody. Joint aspiration for crystals? Nobody. Refer them to orthopedics? Okay. Some people says refer them to orthopedic. Sling and rest? Okay. With regards to tendinosis or tendinitis, rest will just make it worse. That applies to your neck pain, to your back pain, and to your shoulder pain. Okay? If you ask an elderly with back pain to rest in bed, they will lose muscle mass, and you will have more difficulty going back to physical activity later on. The same with the shoulder pain. You could treat patients with sports injury by one of 2 ways. Either a trial of treatment, or you could go for imaging if the case is not clear at all, if you cannot decide where to send them. A trial of physical therapy will take you between 4 and 6 sessions, will cost you around 600 to 800 to 900 riyals, okay? And you will have the treatment already for your patient. If you send them for an MRI, it will cost you 1,500, and you have not started any treatment. So if you are sure about your diagnosis, please send them to physical therapy. In Saudi Arabia, physical therapist usually is a method of treatment, but in the UK and other countries, they do also the diagnosis over there. So please be specific when you send to physical therapy. Otherwise, they will not give you the results that you want. So you have to say, 45-year-old lady, right-handed, complaining of right shoulder pain, specifically supraspinatus or infraspinatus, okay, or subscapularis. So specifying it, it will make it easier for them to do what they are supposed to do, and for you to expect the treatment. And they should get better within 6 sessions of physical therapy. Case number 15, how are we doing with time? 2 minutes? We'll talk now about pediatrics. Which one of the following regarding conditioning and training of pediatrics is correct? This is a very common question we receive on a regular basis. And, strengthening training increase both muscle strength and hypertrophy of muscle in pre-adolescence. Studies fail to prove that improved strengthening exercise reduce injury rate. Resistant training increase muscle size. Weight training is better than free weights. There we have a very common question in sport medicine. Should you stop patients at a pediatric age from weightlifting? This is a common question in all the conferences that we receive. So weightlifting will not stop the boy or the girl from growing as long as it is under supervision of a coach. So the answer over here is more of resisted training needs to be done under the machines and not using the free weights. Otherwise, they will injure themselves. And it has to go under the supervision of a coach rather than under their own supervision. So weight training will not stop them from growing. You could use them for better skills for the pediatric, okay? But you have to make sure that they don't get injured while they're doing the training. So I'll not go through the other cases because we have limitation in time, but I will end up with Umar radiallahu anh. He said, علموا أولادكم الرماية والسباحة وركوب الخيل. Teach your children archery, swimming, and horseback riding. It means that for exercise to be embedded in a community, it should start from you and then transferred into your children. Parents that exercise have a very high probability for their kids to exercise. So please be the role model as the medical community for your patients and for your kids. Thank you very much.
Thank you very much, Dr. Ziyad, for this interactive session. We have one more session before the break. In primary care and family medicine, we daily faces a problem with gastric pain, irritable bowel syndrome, and other GI symptoms. We have Dr. Ahmed Mahmoud today with us to update us about what's new in GI. So please welcome Dr. Mahmoud.
Assalamu alaikum. Bismillah. Thank you. What is this? Is this? No, it doesn't work. Okay. Okay. Good morning, ladies and gentlemen. Assalamu alaikum. So I've got gastroenterology, so GI updates. Obviously, half an hour isn't a long time to go through all the gastroenterological issues you might come across as family physicians, but we'll try and go through some main bits and pieces, and hopefully anything new that's come up in the literature we can have a look at. Okay. So plan is just to go over PPI safety. We'll talk about that because there's been a lot of discussion about the safety of PPIs. Maybe have a look at the dyspepsia guidelines, have a look at colorectal cancer screening, Helicobacter pylori, which is common here, celiac, which again is something we need to talk about. If we have time, we'll have a look at IBS and non-alcoholic fatty liver disease as well. Okay, so over the last, I would say, 5 to 10 years, there's been a lot of discussion about proton pump inhibitors, probably the most prescribed drug for us. Yeah. So omeprazole is a common one, Nexium, pantoprazole, lansoprazole. We all prescribe them. Yeah. Recently, there's been a lot of discussion about the side effects of these medications. So these are the kind of rumors that we've been hearing from the studies that have come out. So do they cause malabsorption? Do they cause osteoporosis? We can ask Dr. Shakir later. Cardiovascular disease, chronic kidney disease, dementia, Clostridium, C. diff, and GI cancers have all, this drug's been linked with all of these. So just quickly going into, this actually culminated in a study that was a large study that was published in the BMJ Open in 2017, which showed increased all-cause mortality compared with H2 antagonists for PPIs. So essentially what they found was the use of PPIs does increase the risk of death compared to receptor H2 blockers. So that was something that caused a lot of issues and a lot of fear in prescribing them. And the other studies initially that were showing there were links to using PPIs would increase C. diff rates, using PPIs would increase dementia rates in some patients, and you'd have patients coming into the clinic saying, "Oh, doctor, I read this about using this drug, it's going to cause me to more likely to be demented. Is this true?" So some of these studies were causing a lot of anxiety among the patients. There was one about risk of fractures, which showed modest increase in the risk of hip, spine, and any site fracture. There were links with osteoporosis, although that one, most of the studies showed there were no links. And there was even a study that showed you had an increased risk in gastric cancer. So there are a lot of question marks and a lot of issues with some of the probably most commonly prescribed medications that we have. But most recently, we've had a large study, which is probably the best study, which is a randomized control trial, 20,000 patients, which was published in Gastroenterology and the New England Journal of Medicine very recently, about a couple of months back, which showed that no association between PPI therapy and all of these outcomes. So, and this is probably a better quality of study than what we've had previously. Most of them were cohort studies and observational studies. But again, we can say the evidence is mixed. But what's the take home on PPIs, and what's the guidance from the gastroenterological societies and the American College of Gastroenterology? The guidance is, don't prescribe it if you don't need. This is the take home. Don't prescribe it if you don't need to prescribe it. There's a lot of people that are on PPI. You ask them, why are you on this? They don't really know. I take a lot of medications. The doctor gives me this. I should take it in the morning. They don't have any indications to take it. So if there's no indication to prescribe a PPI, don't prescribe it. And if there's no indication for the patient to take it, he shouldn't take it. However, the quality of evidence against it and linking it to all of these other pathologies is not strong. So we do have strong evidence that PPIs are the best medication for reflux. They're the best medication in use of in treating Barrett's esophagus. They're the best medication when you're trying to protect it when you're treating a patient with NSAIDs and you need to protect their gastric mucosa. So we know that they work really well. But what we can say is, if there's no indication, don't take it. If there is an indication, we give the lowest effective dose for the shortest period of time. So they're your three take homes. Lowest dose, shortest period of time, only if you need it, okay? The other thing that I didn't mention, H2 receptor antagonists have even had some question marks recently. I don't know if any of you prescribe ranitidine, Zantac. There's been some issues with those. They've been pulled off the market here in Saudi Arabia and in other countries as well, linked with some possible carcinogenic effects of ranitidine as the drug. It's not the class. The H2 receptor antagonists in general are thought to be safe, but there was an issue with ranitidine specifically, but that's still developing and they're still doing more tests on that. So I'm not going to really comment on that, other than we probably shouldn't be prescribing ranitidine at this point. Okay, so moving on. So dyspepsia, very common again in the family medicine clinic. We see a lot of dyspepsia, a lot of gastroesophageal reflux. Always, firstly, make sure that it's not caused by you. So you prescribe the patient NSAIDs or steroids or certain types of antihypertensive which have caused the dyspepsia. And offer the simple advice first before you dive into drugs. Let's make sure they're eating healthy food, they're not smoking, no alcohol, no coffee, no heavy meals before bed. Raise the head of the bed, lose weight, and keep an open mind, make sure you've got the right diagnosis. Red flags are important, so if any of these are present, then you need to rethink your diagnosis. So beware of weight loss, bleeding, anemia, dysphagia, or masses on examination. Managing GERD, the NICE guideline says we should go for either PPI treatment or, managing dyspepsia. We should call this dyspepsia. We should go for PI treatment, or we can test and treat for Helicobacter pylori. And I would suggest here it's very common, H. pylori, so testing and treating would be a reasonable option for anyone that comes with dyspepsia. And it's associated with reduced dyspeptic symptoms compared to PPI, so it's probably the preferred option. All PPIs are virtually the same. I know some people say, oh, this one worked, this doesn't work. Studies show that they're all virtually producing very similar effects. But before you do the test for H. pylori, so the stool test or the breath test, you need to stop the PPI for at least 2 weeks. And actually you need to stop all antibiotics as well for 2 to 4 weeks. So be careful when you send someone for a H. pylori breath test or stool test that they're not on PPIs and antibiotics for at least 2 weeks, preferably antibiotics for a month. referral, so the NICE guidelines suggest that anyone with new onset, well, I think anyone with new onset dysphagia over the age of 55 needs referral. So someone comes to you, they've never had dyspepsia before, they haven't complained of these issues, and then suddenly, over the age of 60, they get significant issues, you need to think about referring them. And then anyone that comes with any type of red flags obviously needs referral, and we've discussed the red flags. And here are some other indications for referral from NICE. So if they've been non-responsive to treatment, those ones who are considering surgery, so the symptoms are so bad they want to do some kind of surgery to reduce the reflux or dyspepsia. Those who have been diagnosed with H. pylori and have had 2 different treatments for H. pylori, so triple therapy and then followed mesolan by quadruple therapy, and we'll have a word about H. pylori treatment. If two rounds of therapy haven't worked, then you should refer them for endoscopy. And people that you're worried about, Barrett's esophagus. The American guidelines, there were some new guidelines 2 years ago saying that if they're over 60, obviously we need an endoscopy. If they're under 60, you should start with test and treat for Helicobacter pylori. So similar to the previous guidelines we talked about. If there's no response to treatment of Helicobacter pylori and no response to PPIs, you could try a prokinetic, which has been shown to be helpful. So something like metoclopramide, domperidone. And if that doesn't work, you could even try a tricyclic antidepressant, a TCA, which as well has been shown to be effective, mildly effective in dyspepsia symptoms. Even psychological therapy has been used for functional dyspepsia. Functional dyspepsia is defined as dyspepsia pain that with a normal endoscopy. So if there's a normal endoscopy, then you could start even thinking about psychological therapies, tricyclics. These things can all help with functional dyspepsia. The other thing that was interesting was that recent studies have shown that maybe alarm symptoms in younger people are not so sensitive. So if there's a younger person complaining of more alarming symptoms, dysphagia, they might not relate very closely to pathology. But again, I would still take alarming symptoms into account. If someone presented with alarming symptoms, I think they deserve an endoscopy. Okay, so moving on to H. pylori. There's lots of tests for H. pylori. There's the blood test. We don't do the blood test generally because if the blood test's positive for H. pylori, it will always be positive. So you won't be able to tell if this is a present infection, a past infection, or if it was an infection with it many years ago. So the 2 tests that are used usually are the urea breath test and the stool antigen test. In the NICE guidelines, we have a 7-day BID treatment as first-line eradication therapy, PPI, amoxicillin, and clarithromycin or metronidazole. And the second line is PPI, metronidazole, and levofloxacin. And there's other options, you can see them there. And the NICE guidelines say if you're unsuccessful after 2 treatments, you refer for endoscopy. The American guidelines, I think, are better, even though I am a UK trained and NICE guidelines is kind of what I trained with. But I think the American guidelines are more reasonable because they take into account drug resistances, and everywhere drug resistances are different. So in the States, you have high clarithromycin resistance. It's increased from somewhere around 1 to 5% up to over 20 to 25%. So using clarithromycin is not going to be very useful in where more than a quarter of the patients are resistant to it. So you've got to take into account local resistances, and that's something we need to build here as well, in that we need to find out what are our local antibiotic resistances. I don't know if you have it available here. I don't know what resistance data you have. Local resistance data is available, but any local resistance data would be useful in determining which antibiotic you're going to use for management of H. pylori. Essentially, the main difference is if you've used recently a macrolide, there's no point of using it again. So if I took azithromycin for a chest infection recently, I'm not going to give clarithromycin as part of my H. pylori eradication. It wouldn't make any sense. Yeah, take into account local rates, and the other difference is it's a 14-day course. The US guideline is 14 days, not 7 days. And there's a confirmation testing for H. pylori at the end of it. So about 4 to 8 weeks after the the eradication therapy, we should recheck a breath test or a stool test. And here's just an example of some of the American guidelines, treatment therapies. So they have triple, actually they don't have a first line anymore, which is a good thing. You have to decide what the patient has taken before, you look at the local resistances and you decide what you want to give. So you can start with triple therapy, you could start with bismuth quadruple therapy, you could start with non-bismuth but quadruple therapy. They've even got various sequential therapies. So there's options. Dr. Basidan covered this already, but I mean, it's very important. There's a high, if you look at this graph, if you catch colorectal cancer early, the survival rate is excellent. If you catch it late, the survival rate becomes gradually worse and worse, and then falls off to something very low. So colorectal cancer screening done properly will save lives, okay? So I think this is one of our take-homes as family physicians. We need to be doing our colorectal cancer screening across the population. And this is evidence-based and will certainly bring results. Now, the recent guidelines, and again, I think Dr. Basudan covered it, but I'm just going to go for tier 1. I think all the guidelines agree that after 50 years of age, all our patients should be having a colonoscopy every 10 years or a stool test every year. And the gold standard of stool testing is the FIT. I don't know if any of you request stool tests. I don't know if any of you know what kind of stool test you have here for fecal occult tests. Does anybody request those? Because our fecal occult tests can be 2 types. They can be guaic and they can be fecal immunochemical test. And the immunochemical test is much more specific for human blood DNA. So it won't come out positive if you eat something with blood in it, like if you like your steak rare, that could give you a positive guaic test, but it won't give you a positive FIT test. So the FIT test is more specific, and I would definitely, we would, all of the guidelines are moving towards the FIT test if you're going to do an annual stool test. The other thing is you only need to do it once, so patients are more likely to do it rather than the three guaic tests we used to do. So in summary with this, start age 50, although the American guideline is for 45 in African Americans, so we start a bit earlier. So if you have a strong family history, so a first degree relative with colorectal cancer under the age of 60 or 2 relatives of any age, then you would do 5-year colonoscopy starting from the age of 40. So we would start earlier and do it more frequently if we have a strong family history. Recent study in the Journal of Gastroenterology, a large study, 130,000 patients, showed that there was an increased long-term colorectal cancer risk after the removal of an advanced adenoma. So if you've had an advanced adenoma removed before or a large polyp, then you need to have a colonoscopy more frequently, so you'd need to have it within 3 years, okay? However, if you've had the removal of a small polyp, a small polyp that wasn't in any way advanced, then you could just have a normal 10-year follow-up colonoscopy. You wouldn't need to have it 3 yearly. Another interesting study, which was from last month actually in the Journal of Gastroenterology, showed that there's a decreasing rate in colorectal cancer in over 50s, and the author postulated that this was probably due to successful screening programs. So successful screening programs have probably reduced our rate of colorectal cancer in the over 50s. However, the flip side is that we have an increasing rate of colorectal cancer in our under 50s. And you'll see that in your practice. You'll see more and more patients below the age of 50, younger patients presenting with colorectal cancer. And again, the author postulates this may be due to changes in life exposures. We're eating differently. We're exposed to different different things in day-to-day life, in the air, in the food, in the water, etc. And some of these things are probably causing earlier cancer rates. We talked about FIT testing, so this is a better test than, this is a stool test which is better than the old test and only needs to be done once one sample yearly rather than the 3-card samples. So that's something we should all be moving to. CT colonography is an option for screening for patients that are really not happy to do colonoscopy, okay? It's not tier one. Tier one is the colonoscopy or the fit stool test. However, if patients are really not happy to do the colonoscopy, they can do the CT colonography. It's shown to be reasonably sensitive and reasonably specific. It picks up small adenomas and small neoplasms, but again, it's not first line. So what happens if you do a fecal occult blood and it comes out positive? What are you going to do? If there's anemia, these are again the American guidelines. If there's anemia, we should do upper and lower GI endoscopy. So if you have a positive fecal occult blood and there's anemia, you need to visualize the entire GI tract. So upper and lower, and if that's normal, you do some kind of small bowel follow through to visualize the small intestines, or CT enterography. You want to look at the whole bowel all the way through, okay? Obviously, if the whole bowel you didn't find anything, then you need to find other reasons for your iron deficiency anemia. If there's no anemia, then at least patient needs colonoscopy. So positive fecal occult blood, no anemia, normal patient, no symptoms, perfectly normal, you do a colonoscopy, always. And if that's negative, you may do an upper GI endoscopy as well, if there's any type of upper GI symptoms. And if negative, you might not need to do any further testing. This is important. Aspirins and antiplatelets, any types of anticoagulants, reduce the value of fecal occult blood testing because they make it much more likely to be positive. If the fecal occult blood, just as a side point, what if they've got iron deficiency anemia with a negative fecal occult blood? So obviously you rule out any other causes of anemia, as you can see on the right. Any causes of anemia, iron deficiency anemia, you need to rule them out. But if you can't find a cause, then you should consider doing an endoscopy. Obviously, you do full evaluation, you do a celiac screen, but you may consider doing an endoscopy if you cannot find a cause for iron deficiency anemia, unless it's a premenopausal woman, in which case iron deficiency anemia is usually explainable. IBS is very common. I'm sure some of us have it, a significant number of us. So IBS is a common disorder, and you'll see it a lot. ABC, we used to say regarding the symptoms, so abdominal pain, bloating, and change in stool passage, straining, incomplete evacuation. Red flags that will make you think that you maybe have got the wrong diagnosis. You should not be getting weight loss, rectal bleeding. Obviously, if you have a strong family history of any bowel or ovarian cancer, you need to start thinking about other possible diagnoses. If someone started getting IBS, it's not something that should start at the age of 55, 60 years. Obviously, anemia, raised inflammatory markers. Diagnosis, make a positive diagnosis of IBS. So you need to just check your CBC, you check your inflammatory markers, and you check your celiac screen. Everyone before a diagnosis of IBS, everyone should have a celiac screen. It's much more common here than we would like to think, and I'll show you. We'll have a quick look at celiac in a minute. We don't need scoping, imaging, and stool testing to diagnose IBS, although there is something about Giardia, which I'll come to in a minute. So obviously diet's going to play a really big role. You're going to try and increase soluble fibers and reduce insoluble fibers, and a low FODMAP diet. A low FODMAP diet, I don't know if anyone has IBS, this really helps. Studies show that the low FODMAP foods will assist in the symptoms, the bloating, the gases, the changes in bowel habit. Basically, if you have a patient with IBS, if you search it up you'll find these, if you search it up on Google, you'll find lots of images like this, which will show you low and high FODMAP foods. You want to avoid the high FODMAP foods because they produce a lot of gas. And they're the foods that will cause bloating, gases, constipation, discomfort, change in bowel habit. So the green is good and the red is not so good. Unfortunately, the red contains a lot of nice food like mango, watermelon, and stuff that everybody likes, but it's tough. So management, first line is antispasmodics. So mebeverine, I'm sure you all prescribe. Peppermint oil, colpomin is found to be really good in treating symptoms. For constipation symptoms, you might decide to use laxatives. There's some newer drugs like linaclotide, which reduces fluid reabsorption from the gut, so it helps with really bad constipation. Second line, you might use the TCAs or even SSRIs. They've been shown to be useful. for IBS that doesn't respond to your basic treatments, and psychological therapies have shown to be useful as well. Recent update in the American Gastroenterology Association guidelines, it was published in Gastroenterology a couple of months ago, which talk about all IBS patients should also undergo a stool test for Giardia, which can mimic IBS symptoms. So that's something we might want to introduce into our day-to-day management of IBS. Stool test for Giardia and fecal calprotectin, which is going to be better at ruling out inflammatory bowel disease than your inflammatory markers. CRP is very non-specific. We should probably not be requesting it anymore. Fecal calprotectin or fecal lactoferrin are going to be very good for ruling out inflammatory bowel disease. Another recent study as well, just to go through a few recent things for you guys. So acute diverticulitis, anyone with acute diverticulitis has at least a 3 times increased risk of developing colorectal cancer. So anyone with acute diverticulitis that comes into hospital should have a colonoscopy within a few months after that episode, and then regular screening, because they're at higher risk. Celiac, I said I'd quickly go through it. I'll go very quickly. Basically, it's much more common than you would imagine. Over 2% prevalence of celiac, and a lot of it is probably under or undiagnosed, and probably a lot of it is labeled IBS. So you get, oh, it's IBS, but which is why we say everyone before an IBS diagnosis needs a celiac screen. And the things that should trigger your mind as a family physician to request a celiac screen: unexplained persistent GI symptoms or IBS diagnosis should all have celiac screens. Weight loss, obviously failure to thrive in kids needs a celiac screen. Fatigue, iron, B12 or folate deficiency, or one or more of them together. Associated autoimmune diseases, type 1 diabetes, thyroiditis, these things might all trigger you to do a celiac screen. And obviously family history of celiac. The test that you would do needs to be done after 6 weeks of normal eating. It's no good putting a patient on a gluten-free diet and then doing a test. It's going to be negative. They need to be eating gluten for 6 weeks before the test, okay? And then the sensitive test is IgA TTG, which is tissue transglutaminase. That's the sensitive test, as long as they have enough IgA. So you have to do a total IgA as well. If their total IgA is normal, then the IgA TTG will give you a 98% sensitivity and specificity, which is excellent. Okay, so that's all you need to do. And you can do endometrial antibody as well if you like. Antigliadin is pretty useless. We don't really do it anymore, or we shouldn't. And then after the positive, if that's positive, you refer for endoscopy. You have to have a biopsy diagnosis which shows villus atrophy, and then you would start referring to a dietitian and start a gluten-free diet. Whenever you review a celiac patient, you measure their height, weight, make sure they're eating normally. You check their symptoms, obviously, and you might do a DEXA scan because they're higher risk of abnormal BMDs and osteoporosis. And obviously, because of their issues with absorption, you're going to check hemoglobin, B12, iron, folate. You're going to check these annually, yeah? And they need probably more vaccinations than usual, so they need a meningitis, a Hib, and a regular flu vaccine because they have a risk of an underactive spleen, and beware of a slight increased risk in lymphoma, very slight. This is just a recent study, again, published a couple of months ago, which showed that early gluten exposure in kids with genetic predisposition to celiac disease may accelerate celiac disease. So there's a discussion about should we be restricting gluten exposure to kids below 5 years or not. It's not clear. There's no guideline on it, but they're going to obviously need more studies on this. But it's something to keep your eyes open for. This is a treatment that we're using for resistant C. diff now. So fecal transplantation is a new treatment that's very, very effective in treating antibiotic-resistant C. diff. However, recently the US FDA reported that there were 2 cases of fatal extended E. coli the patients actually died because the fecal transplant had the extended beta-lactam resistant E. coli from the donor. So obviously before any fecal transplantation, the American College of Gastroenterology is suggesting that the feces should be very closely monitored. Last thing, we're going to talk about liver function tests. Everybody, you often get patients that come in with a high ALT, and we just say, oh, it's fatty liver, don't we? We say fatty liver. Anyone with a high LFT should have severe disease excluded. So first thing I usually do is repeat the LFTs and then do a workup, as you can see, and then you work out AST over ALT ratio. The AST over ALT ratio gives you a good idea of whether it might be non-alcoholic fatty liver disease, which is something that's very common. If it's less than 0.8, it's more likely to be this. If it's more than 0.8, you're more likely to have more severe disease, and you might be concerned. You might want to go ahead and do your viral hepatitis serologies. Obviously, you're going to rule out hemochromatosis and various autoimmune diseases, antitrypsin, Wilson's disease. You might need an ultrasound as well. Obviously, if the ratio is high, if your LFTs are not coming down, or if you have any other worries, you might want a hepatology opinion. It's very common, non-alcoholic fatty liver disease, very common linked with diabetes and metabolic syndrome. And the most important thing is lifestyle. There were recent studies actually, especially in diabetics, which showed that in non-alcoholic steatohepatitis, which is the next stage where the liver becomes inflamed, maybe vitamin E supplements and pioglitazone are useful. They improve the histology. Vitamin E and pioglitazone improve the histology in NASH, which is non-alcoholic steatohepatitis. Lifestyle, even a 5% weight loss, this is what patients need to know. Even a 5% weight loss leads to significant histological improvement. So they can really improve things by losing some weight. And this is a recent study. This is my last slide. This is a recent study and new guidelines from NICE, backed by NICE and the American Gastroenterology Association, which was news to me actually, which is how you would treat someone with suspected non-alcoholic fatty liver disease, where you were worried about NASH and fibrosis. So and these are family physician guidelines actually. So if there's raised ALT, no alcohol, negative chronic liver disease screen, and you think there's a fatty liver on ultrasound, you do a FIB4. FIB4, you can look it up, is basically ALT, AST, platelets, and age. You put them into the calculator, it gives you a number. The number's either going to be less than 1.3, which is low risk, which you're just going to manage by lifestyle. It's going to be more than 3.25, which is really high risk for fibrosis. You're going to refer to hepatology. Or it's going to be in the middle, which is 1.3 to 3.3, basically. And you need to do this test, which is basically 3 biochemical markers for fibrosis, which you may or may not have. They're quite specialist tests, but they're just blood tests, and that gives you a really good idea of whether there's fibrosis there or no. Anyway, that's pretty much a wrap up. If there's anything you remember from this lecture, remember PPIs, lowest dose for shortest period of time, if and when you need them. Dyspepsia guidelines. H. pylori, beware of local antibiotic resistances. There you should really guide your antibiotic prescribing. FIT testing is your best stool test. FODMAP foods for anyone with IBS. Never forget celiac, because it's much more common than you might think. And lifestyle helps with all of these diseases. Thank you very much.
Thank you, Dr. Mahmoud. We still have time. Can we go to do one of the lecture afternoon to do it now? Or you prefer to take the break now? We can get the lecture. It will be quick lecture for 15 minutes, and then we'll have like 10, 15-minute question, and then we'll have the break so we can finish early. So we will get the update in mental health with Dr. Shafiq. Dr. Shafiq, as I mentioned yesterday, he's our head section. He got his medical school and postgraduate education from UK. So please welcome Dr. Shafiq.
Okay, so it's my job to talk about a slightly more depressing topic, unfortunately. Mental health, unfortunately, all over the world is really underserved to the community and our patients. Unfortunately, I think it's still quite a big taboo subject amongst our patients and amongst us as physicians. We tend to shy away from asking our patients and screening for depression and stress and anxiety, and our patients equally are hesitant to come forward and tell us about their symptoms and their life problems. So it's a two-way approach, I think. I think it's important for us to raise awareness about mental health and also raise awareness amongst us as physicians that we need to be screening patients for mental health. One of the new things that's come up in mental health is this concept of mindfulness. We'll touch a little bit about mindfulness, depression, quickly about bipolar disorder, and then probably one of the most important topics for us as primary health care physicians is mental illness and physical health. And then if we have time, we can touch on insomnia. So mindfulness, what is it? It's basically, we spend most of our lives worrying about the future and the past, and not really living in the present. And one of the things that mindfulness does is paying attention in the present moment and non-judgmentally. And some of them say as if your life depends on it. This is the training that you have to go through in mindfulness. It's a little bit like cognitive behavior therapy. And nowadays it's such a hot topic that it seems to be recommended for everything from anxiety, depression, even pain management. And it's more of a life skills rather than therapy. And same like exercise and eating well, we can all probably benefit from it. There's an interesting editorial in the BMJ that the evidence is convincing in the treatment of depression and anxiety. Meta-analyses for depression and anxiety typically reported treatment effects in the moderate to strong range with mindfulness therapy. These effects, although when compared to placebo, were a little less effective, but still they were quite useful. And the outcomes, interestingly, are comparable to those seen in antidepressant trials and without the toxicity. So really, I think one of the things that prevents our patients from taking the antidepressant medication or the anxiety medication is the side effects and the fear that they will be dependent on this medication for a long time, if not lifelong. And I think that we need to try to incorporate a lot more of these alternative therapies when we see these patients. Evidence that mindfulness-based interventions may be helpful in a range of other mental health conditions, schizophrenia, spectrum disorders, eating disorders, addiction, and even sleep disorders. Although the evidence is less robust in these conditions, there is some evidence. And even, as I mentioned, chronic pain. There are some unanswered questions about the methodology and the problems that limit the strength of some of these trials. There seems to be a popularity effect with mindfulness. It's a hot topic at the moment, and maybe that's why the patients seem to like it. One of the most interesting trials actually has been in the relapse of depression. Relapse rates are quite high with our depressive patients. Some studies have reported between 50 to 80% of patients who've been treated with depression in the past are likely to relapse. And the guidelines would suggest continuing maintenance antidepressants for at least 2 years if someone has had a second episode of depression. And evidence suggests that this would reduce the odds of a relapse by 50 to 70% if you take it for 2 years after the second episode. However, as I mentioned, the compliance rates to antidepressants are very poor, and many people express a preference for cognitive behavior therapy and psychosocial interventions long-term rather than taking medications. So this study adults with 3 or more previous episodes of major depression and were on antidepressants were recruited in primary care. They were randomized to either mindfulness-based cognitive behavior therapy with support to taper or discontinue antidepressants or to continue with the medication. They were followed up for 2 years, and the mindfulness-based therapy consisted of 8 weekly group sessions, 4 refresher sessions every 3 months for the following year, and 87% of the patients completed the program. The results, there was no significant difference in the time to relapse or recurrence of depression. In both arms, the relapse rates were high, as expected, 44% in the mindfulness group, 47% in the drug group. So like CBT, mindfulness-based CBT functions on the theory that when individuals who have historically had depression become distressed, they return to this automatic cognitive process that can trigger a depressive episode. And the goal of mindfulness is to interrupt these automatic processes and teach the participants to focus less on reacting negatively to this incoming stimuli, whether it be stress or family issues, financial issues, work stress, and instead accepting and observing them without judgment. And this mindfulness practice allows the patient to notice when these automatic processes are occurring and to alter their reaction to these stimuli. And research is supporting the effects of mindfulness-based CBT in people who have been depressed 3 or more times, and as the previous study showed, demonstrated reduced relapse rates by 50%. There's another study in Netherlands where they looked at mindfulness-based stress reduction in family physicians. This was published in the BJG, British Journal of General Practice, in 2016. And they were offered mindfulness-based stress reduction training, and resulted in an increase in their well-being and reduction of symptoms and of burnout. As one of the founders of mindfulness, John Kabat-Zinn, he said, "You can't stop the waves, but you can learn how to surf." And this is one of the founders of mindfulness. He actually has a center for mindfulness in medicine in the US. And has done numerous programs and is author of numerous books on mindfulness. And there's a lot of, if you search it up on Google or YouTube, you find a lot of exercises that you can do and how to practice mindfulness. Moving on quickly to depression. So non-pharmacological management, I think we've said this throughout all of the chronic diseases that we've talked about. Non-pharmacological management of depression remains the key, and cognitive behavior therapy has proven in multiple trials to be just as effective as antidepressants, and mindfulness now with multiple trials is as effective as antidepressants in preventing relapse rates. Another new form of treatment is this repetitive transcranial magnetic stimulation. And this is holding an electromagnetic coil next to your head and your scalp with the intention of inducing electric currents in the cerebral cortex. It's been compared to ECT, but it's different. You don't need anesthesia. It can be done in the office, in the outpatients. And there's limited evidence to show that it is effective compared to sham stimulation. There hasn't been any major safety concerns. It's not associated with any memory loss. 10% rate of headaches after this treatment. Interestingly, it's been approved by NICE and the American Psychologists Association. So this is one of the new treatments that may come in the following years. Another new medication, vortioxetine, is atypical antidepressant, serotonin modulator and stimulator, and the trade name is Brintellix or Trintellix. And this is an option for major depression in patients whose depression has not responded adequately. to 2 or more antidepressants within the same current episode. Some short-term studies have shown it is superior to placebo for moderate to severe depression, and it appears to be well tolerated, lower rates of sexual dysfunction and other side effects, but further research is obviously needed. Another important mental health issue is bipolar disorder. And one of the things that is important, I mean, it's common, affects 2% of the population, and really associated with high disability and high risks of suicide. Unfortunately, it can easily be missed, and because most of these patients will present to us in the depression phase, and unfortunately, incorrectly, they will be started on antidepressants, which would really trigger a manic episode. And therefore, it's vitally important that whenever we start patients on with depression, that we ask them if they've ever previously had any manic episodes. And the suicide risk in bipolar disorder is 20 times higher than that of the general population. Often presents in a younger age group and does run in the family, so there's a strong genetic influence. There's some new NICE guidelines in the UK, and as I mentioned, asking patients when you're treating them with depression about any overactivity or disinhibited behavior, especially if there's been any family history of bipolar disorder. And you can ask them if you've ever in the past experienced mood that has been higher than normal, if they have extra energy, they felt that they don't need to sleep, obviously excessive spending, they go on shopping sprees and things like that. And if they answer yes to any of these questions, then really further evaluation and even referral to psychiatry is important to make the diagnosis. So if they present in the manic phase, then really if they're on antidepressants, they should be stopped. Antipsychotics are the first line treatment for bipolar. If they're on lithium, then really you should check the levels and increase the dose if they're subtherapeutic. And you can consider adding an antipsychotic to their lithium therapy. If they're in the depression phase, then quetiapine alone or an SSRI like fluoxetine with olanzapine. Lamotrigine, if there's no response, can be considered. Again, if they're taking lithium, check the levels and make sure that they're therapeutic dose. And if they're on maximum dose of lithium, you can add fluoxetine and olanzapine or quetiapine alone. Relapse prevention, lithium is still the first line and the most effective. If it's not, then valproate can be an option, or olanzapine. Psychological interventions, including CBT, interpersonal therapy, is very important, and educating the patient about their condition is extremely important. Mental illness and physical health. This quote really shook me, actually, scares me. This was a quote in the BMJ. The huge loss of life among people with mental illness needs to be recognized as a human rights disgrace. And these are the patients who tend to get, either they tend not to come to our clinics because they always no-show, they always don't take their medication, they have no desire really to improve their physical condition. And these are the patients that tend to get ignored. You ask any physician, what is your heart sink patient? It will be one of these patients who has diabetes, heart disease, and also has a mental illness. And unfortunately, they do tend to get ignored by the healthcare personnel. It's one of the most important comorbidities, and the link between severe mental illness and increased mortality with patients with their cardiovascular disease or diabetes. Psychiatric male patients die 16 years earlier versus controls, and females 12 years earlier. And the majority of this excess mortality is actually due to the cardiovascular disease and cancer. Not because they commit suicide, and that's why the mortality. And suicide was the cause for only 13% of this excess mortality. So these patients die from their chronic diseases because of their comorbidity with their mental health. And this has been shown across different decades and in different continents all over the world. So how often should we review patients with mental illness who have chronic diseases? Obviously at baseline, at diagnosis, and then 3 months, and then annually. And we should monitor their, if they have rapid weight gain, review their smoking, exercise, their diet, assess their weight, BMI, blood pressure, check their sugar, cholesterol, ECG, and we should intervene when we find positive findings, not just screen and then concentrate. The patient has a mental illness. He's not going to listen to me. These patients need more intervention. Encouraging nutritional counseling, lifestyle, and behavioral change, and treating them with drugs for their hypertension, diabetes, and cholesterol. Quickly touch on insomnia. When I came 2 nights ago and sleeping in a new hotel room, I couldn't sleep for half the night. I was tossing and turning. The pillow wasn't right. The bed was uncomfortable, and I realized that I'm going to talk about insomnia. That if a patient has insomnia, the number of times we just give them sort of easy advice. Make sure you exercise, have a hot milky drink before you sleep. These patients work all day. They are tired, and yet every night they go home and they cannot sleep, and they're tearing their hair out. I tore all my hair out with insomnia. So we have to assess and look for secondary causes. There's primary insomnia, the sole cause is in only about 12% of cases. So a lot of these patients have secondary causes: external stimuli, psychological distress, physical health problems, maybe the coffee they're drinking, stimulants, some of the medications they're taking. So really need to take a good history and make the diagnosis and treat the underlying cause, along with obviously the usual sleeping advice, sleep hygiene advice. And one of the things that we're seeing more and more of now is our patients spending more time in bed but not sleeping. And unfortunately, one of the reasons is our mobile phones. We go to bed and then let's catch up on our emails, let's catch up on social media, and you spend about an hour with the light staring at your eyes, and then when you try to sleep, you can't sleep for another hour. So really, you should cut down on sort of ineffective time in bed, advise bedtime restriction. So if you calculate how long you sleep for and how much time you actually spend in your bed, I mean, if you wake up at 4 or 5 in the morning and you're tossing and turning, you should wake up and just go do some exercise, read a book, do some studying or something like that, but really not spend too much time in bed when you're not sleeping. CBT has been shown to be effective in insomnia, as effective as hypnotic drugs. We know that hypnotic drugs have lots of pitfalls. They can be severely disabling, linked with falls in the elderly, addiction, tolerance, cognitive impairment, even dementia, accidents. So really, it should be a last resort. We should not be the first thing the patient wants is a drug to make them sleep. And really, we have to explain to them that this is a last resort and try to find the causes, as I mentioned. And really, if you really do need them, then you should use them for the shortest possible time. If you take these medications for 7 to 10 nights every night, that's how quickly you can build dependence. So it's very important to tell them to take it for 2 or 3 nights so that they get a good night's sleep, and then take a break, or take it maximum 3 nights a week, and not for more than 2 or 3 weeks at a time. The other thing which is useful is melatonin. Recently I had a patient who really for 6 to 9 months has not been sleeping. And he asked me about melatonin, and as a last resort, we tried melatonin. Within 2 to 3 weeks, he was sleeping in the night. So it's very effective. It's also very effective when you travel with jet lag. Sometimes when you're coming from a long journey, you cannot sleep for 4 or 5 nights. Melatonin has been really shown to be really useful with jet lag. Okay, with that, I will not delay the questions and lunch. Thank you.
Dr. Ziad, Dr. Mahmoud, please. So we have 10 minutes for question before the break. So if anyone has a question for about mental health, about sport medicine, or about GI diseases, it's the right time to have the question. Yes.
Assalamu alaikum. Thank you, everyone, for the great lectures. Dr. Ziad, did you introduce ultrasound at your clinic for maybe diagnosis, at least, some musculoskeletal issues?
Well, I have it in my clinic, yes. I have an ultrasound in my clinic. Am I practicing it on a regular basis? Unfortunately, no. I went to 2 courses of ultrasound, okay? When I first came from Canada, I was doing it on a regular basis to understand it. But now with a busy life in the clinic and outside the clinic, it became more difficult to maintain the skills. But this is the future of sport medicine interventions and treatment. It's not just making a diagnosis, it's also doing treatment. I used to give plantar fasciitis injection, ultrasound guided. Okay?
Yeah, I think for us as family physician, we should introduce that, even for our resident and program, to have it in our clinic for us and for the future family physician too.
وفي الER عندنا الحين they are using it on a regular basis to do the scans, especially if the patients come with an acute abdomen, and they have courses in King Faisal and Riyadh on an annual basis for abdominal and ER specific ultrasound, and I believe this is one of the best courses. In the King Fahd Medical City, they have the ultrasound courses for musculoskeletal. So if you go into their academic calendar, they have it on a regular basis. And there are certification in it in the United States, where you have to go through certain courses to be musculoskeletally certified family physician to give the intervention and make the diagnosis.
Thank you.
Thank you, Dr. Ziad. They mentioned that the ultrasound is the new stethoscope, so it will disappear, especially from emergency. Yes. We have question.
Microphone هنا يا دكتور.
Yeah, في here.
Assalamu alaikum. Al-Amraidi family resident. I want to ask Dr. Ziad about the diabetic patient after exercise having carbohydrates. So is it like mandatory for all diabetic patient to have carb meal after exercising, or for some patient or so?
Usually with exercise, you could predict, the best predictor for your patients is your patient. They know what happens to them during and after exercise. But from our knowledge right now, we know that a patient who exercises for half an hour needs a replacement by 30 to 50 grams of carbohydrates. So the one thing that we need to avoid is to have a bad experience for our patient when they exercise. So that will stop them from exercise in the future. And we know for a fact that diabetes needs lifestyle modification, and we need to facilitate it for them as much as possible. So asking them, especially patients on insulin, to increase their carbohydrate intake after half an hour of exercise is very important to avoid hypoglycemia.
Thank you.
Yes.
I have a comment on one of the slides you show about this rotator cuff tear. You told we can give advice to start PT if we are sure from diagnosis, but we never can be sure from diagnosis from clinical diagnosis. We are not seeing inside, and all giving the positive test. So how can I advise PT without knowing the proper diagnosis? This is the first question. Second question, also one of the slides about femoral impingement syndrome. This is very dangerous. I can't also be sure from this femoral impingement syndrome. There is many causes causing hip pain. So I have also be sure from diagnosis with investigation. That should be MRI. Many questions like this. Also, I noticed too, or say you are giving one-point treatment and it can harm the patient without, I'm not sure from the diagnosis, 100%.
Thank you very much.
So because this is my specialist.
Yeah, بالعكس يا دكتور. This is an excellent question. What we say usually for, يعني we, all of us teachers in the Al-Faisal University, and when we try to talk to the medical students about that specifically. And as we grow in our practices, as a consultant, as a specialist, we drift away from our usual practice. Our usual practice in the past, when we first graduated from medical school, all of us, is to take very detailed history and physical examination. When you go into the medical education, you find that the consultant and the resident goes to the same results, but the consultant take shorter period of time, because they utilize more of the laboratory test, more of the x-rays, more of the radiological test, and they don't go into the details of the history. What I'm trying to focus and emphasize over here is if you have very detailed, proper history, and you are sure about your physical examination, that will take you into 90% of the diagnosis of your conditions, okay? So if you reach 90%, when we do the Toronto criteria for sore throat, it takes you to 60% and you are sure 60% and you prescribe antibiotics. So if you are 90% sure, there is no harm in doing a trial of physical therapy. I believe there is no harm. The harm, if you refer the patient to orthopedic, that will take them 6 months to be seen by orthopedic. In our hospital, it takes us 1 year for a patient to be seen by orthopedic. So I cannot wait for a whole year for that patient to be diagnosed, to be treated. You understand what I mean as a family doctor? It's very, very important. In terms of impingement syndrome, rather than sending them for an MRI, I would send them for an orthopedic surgeon, because it's cheaper and they might start initiate the treatment and the injection at the same time. I'm talking from a sport medicine perspective. We do these on a regular basis. We took 2 years of subspecialty and do it on a regular basis. So I'm taking it from a specialty point of view rather than from a generalist point of view. And I want to focus, I want to introduce these concepts to the attendees of the conference. What I want you to get out of it is to understand that there is something called impingement syndrome, and you need to make a diagnosis out of it using the understanding the symptoms and utilizing your resources appropriately. These are the 4 messages I wanted to send from the sport medicine presentation, and I hope I was able to reach that point.
Can you use the microphone, please? Can you use the microphone, please?
If I send him to PT direct, maybe minor tear that can be conservative managed is transferred to big tear. And this I get harm for him with the PT. So we are making, I'm a resident orthopedic, so I'm making a safe thing. I'm keep him in rest until I'm sure from the diagnosis.
Sure. Just for the short of time, I will take over, Dr.
Until
Ziad. I think
we could discuss it later after the...
And there is clear between protective medicine and active medicine and how to differentiate that. We don't want to do MRI for all our patients, especially in primary physician, as a family physician or primary doctor. So we can take it more in details with Dr. Ziad later. But I think the message is you need to know how to take the history and you need to know how to do the examination if you have doubt and you have the facility to do MRI or to use the other specialty. But this is sometimes is not the case. Sometimes you don't have MRI. So what you will do, you will not treat the patient. So it's a lot of multifactorial, but the basic knowledge about taking history and examination and know the differential diagnosis, because number 1 cause of medical errors is lack of knowledge. So if you don't know something called impingement syndrome, then this is the worst thing. If you know about it and you know how to do the examination and take the history, then you will solve a lot of problems. Some cases for sure you need further investigation or help. Any other question?
Excuse me.
Yes, please.
Khalil Qadis Yasar, neurosurgeon, Royal Commission Hospital. My
Can you raise
question-
your voice a little bit louder?
Yeah, Yasar, neurosurgeon, Royal Commission, Khalil.
You're welcome.
My question is to Dr. Mohammed, mental health. I want to just ask, do you have, I mean, our colleague in the psychiatry department, any screening tests for, or guidelines for the newly discovered patients with acute psychosis or something like this? Because we know we have seen some patients who are coming late to a neurosurgeons with specific lesions or some very bad tumor, in the latest stage, who have been treating for a long time with, psychiatrists, with antipsychotics, antidepressant. So my question, we want to know if there is a screening test or something, or guidelines for us, for colleagues, and family physicians who are maybe sometimes ER also patients, just to let them know, especially the radiological imaging for the brain. We need just to know this little
Sure.
your comment about it.
Yeah, I mean, excellent question. I think one of the things is with any sort of atypical presentation of depression or anxiety, with certainly if a young patient has psychotic symptoms, one of the sort of modalities of investigation would be a CT of the brain to rule out any space-occupying lesion or organic cause of their symptoms. So atypical presentation, resistant symptoms, especially psychotic symptoms, I think part of the guidelines is to image the brain, and that's across all ages, whether it's a younger patient, elderly patients, more brain imaging is included in the guidelines and is even more important.
Yeah, I agree. Psychosis is not a primary diagnosis by itself. So if you don't know the diagnosis, you have to investigate and you need to refer for specialized like psychiatry. So psychosis by itself is not something that you can wait for a year or wait late.
And I think in primary care, if you encounter a patient with psychotic symptoms, I think that is one of the criteria for referral to a psychiatrist.
Is a red flag.
Yeah, red
By
flag.
the end, it's a red flag. So if you know how to deal with it, like for me, geriatrician, if I know I'm sure this psychosis for my geriatric is from delirium and I know how to treat it, is fine. But if I don't know what is the underlying, I will do the imaging and I will ask for help from geriatric psychiatry.
I raised this question because we came across some disastrous cases. Unfortunately, they came so late with like GBM tumors, and they used to be on some antipsychotic medications for like a couple of months.
It's happened sometimes.
Yeah.
Thank you to brought it up, and this is the goal from this is our discussion and sharing experience with each other. So thank you. Any further question? Thank you very much, and we'll have our break and lunchtime, and we'll restart by 1 o'clock, inshallah. We have 2 more lectures about dermatology and geriatric, and we'll end up our conference, inshallah. Thank you.
Thank you.
I want to ask question, but he did not allow me. I want to ask you question.
No, it's all right, man.
He did not allow me.
Why? Because I asked you one? We need to get
No.
your audiology. We need to get your audiology check.
I have والله كان عندي سؤال في الغد.
أنا
والله
كنت
كان عندي
أنا
سؤال
كنت
بس.
بسأله. كنت ما خليتني كنت رفعت إيدي
والله ما
كنت أبغى أسأله الفيكل هذا ترانسبلانت إذا نعمل له كلينينج فور
dermatology. Assalamu alaikum and good afternoon. Sorry to be late a little bit. We're gonna start our afternoon session. We have two lecture update in dermatology and geriatric. We start with Dr. Qusay Al-Abd, consultant in family medicine, and he will update us about what is common or important to know about dermatology in primary care.
Assalamu alaikum. In dermatology, I cannot present about dermatology without slides, and I cannot present about dermatology without some interaction. So I would like some interaction, at least think about the answer before we go to the next slide. I'll start straight away with cases. So we have this 10-year-old boy presented with this recurrent itchy rash over the last 4 years. You don't have to shout the answer, just think what it might be. This is another patient. He's 32-year-old, complaining of rash over the last few years. And this is the rash. Another one, 50-year-old diabetic man complaining of 3 days history of a painful leg rash. It's another one, 1-year-old boy who had a flu, and his mother noticed this skin rash, and she brought him to see you today. And another one, we'll speak about them later, just think about the answer. 1-year-old child who had a fever and this rash. Okay. So all of these rashes are erythematous rashes. They divide erythematous rashes into 2 groups. The rash that is scaly, and if you look at the skin, it's rough. And all of these erythematous scaly rashes, we group them into 2 main groups, eczematous and what we call it papulous squamous. And the other group, when you look at the skin, is a smooth skin. There's no scales like this one or this one. We have to know if this erythema is blanchable or not, because blanchable is something simple like cellulitis, but non-blanchable means purpuric rash. So we saw this rash, smooth, and just make sure any smooth rash, smooth erythematous rash, you need to make sure it's blanchable, like this one, or the exanthem that the child had, because it could be purpura. So we divided the rash into rough skin and a smooth skin erythematous rash. The rough are the papulous squamous and the eczematous. Both of them are rough because they have scales, and we can differentiate between them and find out what might be the diagnosis. This is the way dermatologists look at skin rash, erythematous or non-erythematous. Erythematous, we have to make sure has a smooth skin or rough skin. The one that has rough skin, it could be papulous squamous like psoriasis, or it could be a smooth, eczematous like eczema. So when we differentiate, when we look at the skin rash, it's rough, it's erythematous, we can differentiate between eczematous rash and papulous squamous through looking at the borders. The one that has a very clear border, you can differentiate between the problematic skin and the normal skin. This is why we call it papulous squamous skin lesion, which is the commonest example is psoriasis, like this skin lesion. the one that you find it difficult to differentiate between the border. There's no clear-cut border between the erythematous rash. There's no clear-cut border between the erythematous rash and the normal skin. This is eczematous rash. Also, eczematous rash has another feature. There's what you call epithelial disruption. There's oozing. The skin is wet. There is erosions in the skin. And in the chronic cases, you will find what we call it lichenification. The skin becomes thick, and the skin marks become obvious. So we call it epithelial disruption, which is a sign of eczematous rash. We have erosions. We have crust formation because there's oozing and the crusts start forming. There is also fissuring like this one. This is our eczematous rashes. And if it's chronic, we get this lichenification of the skin when the skin becomes thick and you see the skin marks. So when we talk about eczematous rashes, this is a group of skin diseases like eczema, which is a commonest example, also seborrheic dermatitis, scabies, and any other skin rash. If you keep itching, you will develop an eczematous changes. And the papulosequamous, like psoriasis, the commonest example is psoriasis, but also tinea, the fungal skin infection, SLE, discoid lupus, also mycosis fungoides, which is T-cell lymphoma, BCC, superficial BCC, and in situ squamous cell carcinoma. All these are papulosquamous skin disease. Seborrheic keratosis as well, actinic keratosis, lichen planus, and other things. So we'll talk briefly about eczema. Eczema, the distribution of the eczema is different from in infancy, in childhood, and in adults. In infancy, it tends to be in the face, arms, and legs. When the child gets older, it becomes an ancubital fossa in the arm and popliteal fossas in the legs. And in adults, if the patient continues to have atopic eczema, it will be more obvious in the legs, in the foot, under the breast, in the anogenital area as well. This is just pictures showing different types of eczema, a face in the child. This is lichenification happen in a chronic eczema in the arm. And this is small patches of a small eczema in the leg. We call it nammular eczema. Eczema or atopic dermatitis associated with this disease. If you have a child, if you've seen a child with eczema, atopic eczema, you might see the skin is dry. We call it xerosis. You might see it's like a gauze skin. You have this small red papules. We call it keratosis pilaris. And if you've seen a child with this white patches in the cheek, we call them pityriasis alba. Contact dermatitis happen when there is something irritated or the skin is sensitive to, and it happens at the site of the contact or somewhere else. A common example of contact dermatitis happen in DAPA or nappy rash, in lips licking, in a child who keeps licking the lips. So this is another example of a case. This child had eczema for a long time, but suddenly he developed an exacerbation. What do you think might happen? He known to have eczema for quite a long time, and suddenly, over just last couple of days, it got worse, and that's what it looked like. So this is an infected eczema. The commonest cause of infected eczema usually Staph aureus. It can cause sudden exacerbation. The skin become more discharged. You can even get cellulitis. Like this child has got more erythematous skin around the rash. We take a swab. Sometimes we take from the nose because many kids have got Staph aureus in their nose, and if it's positive, you can give them Bactroban, nasal Bactroban. And the treatment, obviously, oral or topical antibiotic, depending on the severity. It's another child who had eczema for quite a long time, and over the last few days it got worse. And his mother brought him to. Can you see these small spots? If you look carefully, there are vesicles, small vesicles. This is what we call herpes simplex or eczema herpeticum. The child has eczema, and then suddenly he got exposed to herpes simplex virus, and then they got exacerbated. Okay, a 65-year-old lady who had this rash for 10 years, bilateral leg swelling, worse on long-standing redness and itching, and occasionally oozing and a small ulcer, or lots of changes in the leg. Yeah. Stasis dermatitis or venous insufficiency. The lady had long-standing varicose veins, and because of the leak of the iron from the blood, from we call it hemosiderin, the color become dark, more in a black side or purple, and the skin get eczematous changes. They get swelling because of the stasis-dependent edema. So treatment for eczema, all eczematous changes in general, we moisten the skin through moisturizers, and we give topical steroid. There is advice from NICE guidelines, advice to leave a gap of half an hour between applying both medication, emollients and the topical steroid. You can give antihistamine for itching, and there's an infection, we give an antibiotic. If it doesn't work, we usually refer to dermatologists, because there are other modalities of treatment that we don't do in primary care, like giving topical immunosuppressant, like tacrolimus. Oral steroid can be given, and even phototherapy. Right, a middle-aged lady, 50 years old, complaining of dandruff, and she's got this skin rash. If you see the rash in her scalp here and in the nasolabial fold. You see, dandruff is always, or not always, many times associated with this type of dermatitis. It's seborrheic dermatitis. It's still type of eczematous changes. It happens on area that carries a hair, so it's in the chest, in the near the eyebrows, near the hairline in the head. And if you look carefully, you can see in the scalp itself with a lot of dandruff. It can also happen behind the ears, retroocular area. In kids, it's the same, you know, the cradle cap the kids get, it's still seborrheic dermatitis, cradle cap. That's different picture of seborrheic dermatitis. In the scalp, cradle cap in a child. This is another eczematous rash, but the itching is very intense. This patient was treated, actually it's a patient, it's not the case from our hospital, but the pictures are not. He's 65, he was treated for eczema, he had a lot of steroid, but none of them are working. They do work, they reduce the itching, but the rash itself keep coming back. And on examination, you see these between the fingers. This is abdominal wall, this is under the axilla. Scabies. Intense itching worse in the nighttime can be a clue. But pathognomonic finding, if you find it, just look carefully for it. You can find what you call it barrows, which is the scabies itself, the organism is just under the skin, lay its eggs and cause some inflammation. The areas that are affected usually under the arms, cubital fossa, between the fingers, and in the anogenital area. It's a child with scabies, barrow, child with scabies. Just whenever the eczema is not settling and the patient is complaining of intense itching, just keep it in mind. Treatment according to British National Formula, or the BNF, recommend 5% permethrin, which is available in the Saudi market, applied to the whole body on the night time, you wash it the next day. And you repeat it in 1 week. And it's advised to treat the family as well, the close contact. Okay, it's another rash. This one is a bit different. So a 35-year-old lady who's been having this skin rash for the last 1 year. Look at the rash. This is different. This is a well demarcated. The margin between both rashes are between the skin and the rash is quite clear cut. It affects here. There are a lot of scales here, and in the knee. This is a picture of the knee, and nails. There's some pitting. Psoriasis. Okay, young man, 21-year-old, 5 days ago he had a sore throat and then he developed this rash. Quite similar as well, although it's a smaller rash and it's an acute onset. And if you look carefully, it's quite similar to the previous one. It's got scales, well demarcated. A group of diseases that we call them papulosquamous. They're all erythematous. They're sharply demarcated. Like I said, the margin is clear cut. And they don't have any epithelial disruption like eczema, and they don't have lichenification, even if they're chronic. Psoriasis. The commonest type of psoriasis that we come across is a plaque psoriasis. There's pustular psoriasis, which is rare, but it's a warning because it can get spread to the rest of the body very quickly. And if you look, it's just pustules in the palm and the foot. And the small one, the small rashes that this guy developed after the flu or the viral upper respiratory tract infection is called gut psoriasis. Psoriasis can be, this is emergency. Erythrodermic psoriasis affect the whole body because they lose fluid very quickly and they lose electrolytes. And it can affect the nails. Thickening, like here, you can get onycholysis, which is you see the nail splitting or separating from the nail bed, and you get this spitting in the nail. One characteristic, a few characteristics of psoriatic rash, they have this large scales, large silvery white scales that you see on the rash, and they have this what we call it Kubner phenomena, which if the patients scratch their body or get an injury, they develop the rash on that part. We call it Kubner phenomena, which happen with a few skin diseases. One of them is psoriasis. And you get this Osbett signs of them as well. Osbett signs, if you remove the scales, you'll get blood spots at the bottom. Plaque psoriasis, the commonest, affect usually symmetrical, both sides, like elbows, in the sacral area. If it is in an area like moist area, like in the groin or under the breast or under the axilla, you don't see scales. It's just a smooth, angry skin like this. Guttate, as I said, is usually after viral infection, and it's a young people, and it's a small. But look carefully on the rash, you'll see the scales, you'll see the characteristics of the guttate psoriasis. Management of psoriasis, according to the British dermatologist, you moisten the skin as well, reduce the scales, reduce the itching. And the number one treatment for psoriasis is a vitamin D analog, which is calcitriol. We have in our hospital, King Faisal, it's available on the market, Saudi market, Dovonex and Dovobet. But in our hospital, it's restricted to dermatologists. I don't know, anybody prescribe in our hospital? Do you prescribe Dovobet over Dovonex here? Okay. So if the vitamin D analog didn't work, or it's not effective, the patient didn't tolerate it, some dermatologists or sometimes use coal tar or Dithronol. Dithronol is not very popular because it irritates the skin more. And if it doesn't work, we should really refer to dermatologists, but many refer after from the beginning because it's a chronic disease. Dermatologists, they use the previous medication. In addition, they can use ultraviolet light and protopic, which is tacrolimus. A70 is a very common thing, especially if you have people from Europe, from and a lot of Arabs as well, especially white-skinned or fair-skinned. So 70-year-old man getting married, he was complaining of this rash and he would like it to be removed. Seborrheic keratosis. Don't get mixed with seborrheic dermatitis. This is seborrheic keratosis. It's completely different. If you look at it, it's like, sorry for the word, it's like a date. Date being stuck. We call it stuck on appearance, on the scalp, on the back, and they are dark, usually dark in color, but they can be lighter in color. If you don't see scales on them, just scrap it and you will see the scales. 70-year-old man complaining of rash on the head and hand, and this is what it looked like under some magnification. So that was seborrheic keratosis. This is actinic keratosis. It's an irritation that happened due to sunlight, so it happened in sun-exposed areas. And it's one of the precancerous conditions of the skin. We always palpate. The treatment for this is just cryotherapy. We apply cold liquid nitrogen to it. But you need to palpate because this is one of the causes for squamous cell carcinoma. If you feel a nodule under this has to be excised. It's a very common condition. Young people get it, old people get it, but it's probably young people more. 25-year-old man has been complaining of this skin rash for the last 1 year. Slightly itchy. Very common. Pityriasis otinia versicolor. They call it versicolor because usually the color of the lesion is opposite to the color of the skin of that person. If the patient's skin is dark, you get whiter lesion or the opposite. And it's still part of the papulous squamous skin lesions. 29-year-old lady who had a sore throat 5 days ago and now developed this skin rash. This came actually in the family board exam recently, this case. If you see, there's a lot of small erythematous rashes. They have well demarcated. You can see one big rash here. This is called pityriasis rosea. Still common. I've seen it twice in our hospital. It is very common after viral illness. And if you see the skin rash, if you look carefully, you might see it's following the rib lines. Ribs line. And this is called herald patch of pityriasis rosea. Rounded, more dark in the periphery. Okay, more pictures of pityriasis rosea. Doesn't need any treatment, will resolve by itself. But it's worrying to the patient usually. Okay, this is also common in Saudi. I've seen it a few times. Referred a few patients to dermatology for long-term treatment. So this is 45-year-old man who is complaining of this rash, very itchy rash for the last 5 months. Look, it's sort of, you can say it's violet color, more dark, red, and it's flat and shiny. It's around in the hand, and this is the wrist, the front of the wrist. Any idea? Lichen planus, yeah, mashallah. Lichen planus. It's a very itchy. It's one, probably what bring the patient is the itching. And it's flat-topped papules. They also have, like psoriasis, they have Kobner phenomena. So if the patient gets scratched very badly somewhere or again injury, the rash develop in that part. This skin lesion can damage the underlying tissue. It can cause scarring alopecia. They lose hair permanently. They usually get nail dystrophy, especially in chronic cases. And if you look in the mouth, you can see this white lacy patches. More pictures of lichen planus. We say it's erythematous, but if you, not always erythema, I mean red, in people with dark skin, it can be like this, like black. There are some medication that we prescribe commonly, and they are associated with like what we call it lichenoid skin reaction. Gives exactly the same skin rash. ACE, ARB, calcium channel blockers, methyl dopa, sulfonylureas, NSAIDs, and some of the anti-malarial medication. We have it, I've seen it a few times, 45-year-old lady complaining of this skin rash and some alopecia, and she's complaining of joint pain. Discoid lupus. I don't know why, but they like it in the exams. I've seen it a few times, but it's an exam favorite. In a sun-exposed area, call it the butterfly. If it happens on an area that has skin, it causes scarring, alopecia, and usually diagnosis, you might need a biopsy for it. These people are at risk of developing the full SLE. So we need to look into the urinalysis, chest X-ray, anti-nuclear antibody, the usual thing. Some more pictures of discoid lupus with a scarring. Okay, this is an actual case from our walk-in clinic in our hospital. She's 79. She came with her family. The resident saw the patient first, and he said, I think there is a burn in the upper limbs, and he was suspecting some abuse, adult abuse. On questioning the family again and again, they insisted actually there is no history that's suggestive of a burn, but they noticed there is redness on the skin, and later on she developed these blisters. You call blisters. A small blister, we call it vesicle, like the one in herpes. A big one, we call it bullous. So a lot of bullous here, bullous here, bullous there. What do you think? Yeah, mashallah. This is another case. This is from the emergency room, fast track. A 70-year-old lady, she came to the emergency twice over the last 3 days. First time she came, she was complaining of headache, one side headache. She had a CT scan, she had a lot of blood tests, all of them came back normal. Eventually, she was told, you have tension headache or migraine, whatever. She was given painkillers and she was sent home. Next day, she came. First thing we saw was she's got some redness in her forehead. And we looked carefully, it may be a small vesicles here. Yeah, herpes or shingles. This is a young man who previously healthy, never been ill, had left-sided chest pain, and later on developed this skin rash. And if you look, you see these small vesicles, also shingles. But what is about this man? He's a young man. Why should he get shingles? You know, shingles or herpes, usually there's some problem in the immunity. This patient was investigated and had lymphoma. So be careful. A young man who gets shingles, always, an elderly probably will accept it. Not accept it as I wouldn't be very worried about an underlying reason, but in a young man, no, or young woman, no. Okay, vesiculobullous diseases, blisters. If it's very small, we call it vesicles. If it's big, we call it bullous. Vesicles like cold sore here, or pemphigoid. If it ruptures, it can cause erosions, which is just very superficial ulcers, erosions. Diseases that mainly present with vesicular lesions are these. Mainly present with bullous or bulli are these. Remember, which is not very common, but it can happen. Tinea pedis, athlete's foot. I'll stop. Scabies and impetigo can have bulli. So this was pemphigoid, and it's common in elderly. Some pictures of pemphigoid. Pemphigus vulgaris is in Ashkenazi Jews. It's not common in anywhere else. Herpes. Shingles. One common thing that you need to look for and be careful when the shingles affect the cranial nerves, because the patient can get keratitis, viral keratitis, and they can lose their vision. So if the patient has any red eye, should be seen straight away by the ophthalmologist. I think I'll stop here. Shall I? Take 2 more? Okay. So a toddler who had this rash for the last 2 days, otherwise he's well. Chickenpox, small vesicles, you can see some small ulcers, scabs. Chickenpox. 17-month Runny nose, fever, develop this skin rashes well otherwise. Just simple skin rash. If you press on it, it is blanchable. They disappear. Blanchable means they disappear. The erythema disappears. Make sure you do the blanching test, because it could be could mean purple, and purple mean some completely different story. So simple non-specific viral rash. They usually spread all over the body, sparing the face and the child as well. And usually there is a recent history of viral illness. This is also viral rash, but the child is very unwell. Temperature is very high. If you look in the eyes, quite red, runny, and if you look in the mouth, you see these spots. What's that? Complex spots. Yeah, measles. So measles, a child is unwell. It's not like a simple viral rash, and they get conjunctivitis and they get this complex spot. 6 years old child who had a fever for a week and then developed this skin rash. Look at his face. Slap cheek or fifth disease or erythema infectiosum, different names, same disease. They develop this redness in the face and the same viral rash all over the body. 5-year-old fever for the last couple of days and develop this rash. If you look in the hand, mouth, and feet. Hand, foot, and mouth disease. 6-year-old had a sore throat, then developed this rash. Look at her tongue. Scarlet fever. Streptococcal throat infection, and the tongue, you get white coated at the beginning, and then the white thing fall off, and they become like quite red and angry. Strawberry tongue, white tongue, then strawberry tongue, and they get this viral rash, or look like viral rash. 4-year-old came to you with this rash around the nose and mouth. Can you see the crust? Crust is just a dried exudate. What's it? It was impetigo. Okay. Sorry, I have to stop here. I had a few more slides, but I think we're running out of time.
Thank you very much, Dr. Qusay, for this intensive lecture about dermatology.
السلام عليكم ورحمة الله. الآن الدكتور لؤي باسودان حيقدم لنا توصيات recommendation for this conference. تفضل دكتور.
Assalamu alaikum. We are really blessed by having engineer Mustafa Al-Mahdi again with us today. We really appreciate his support. We have the recommendation about our conference. I'm sorry, we'll present it in Arabic. And maybe later, if you need, we can translate it. Basically, it's just a few recommendations about each of our lecture. شكرا مهندس على حضوركم وتشريفا لنا. بالنسبة لبعض التوصيات اللي نرى أنها ذات أهمية تطلع من المؤتمر. المحاضرة الأولى كانت أمس من الدكتور عبد الله الخنيزان عن value based medical care، الرعاية الصحية ذات القيمة العالية. نعتقد أنه من الرسائل المهمة التي لازم توصل للمجتمع، الهدف الرعاية الصحية قد يصل إلى 25%. يمكن يكون في المملكة عندنا ما في أرقام واضحة، ولكن ممكن يكون أعلى من كذا. فلا بد من الارتقاء بجودة وفعالية الرعاية الصحية، وهدف من أهداف التحول. التنسيق بين جميع التخصصات الطبية والمريض عن طريق طبيب العائلة، وهذا هو توجه البلد على فيجن 2030. هذه من الأمور المهمة. ننتقل بعد كذا على الديابيتس، مستجدات السكري. طبعا من المهم عدد نسبة السكري جدا عالية في السعودية. السكري وما قبل السكري يشكل 33 إلى 35% من المجتمع، خاصة اللي أعمارهم فوق 18 إلى 20. الوقاية من خلال الفحص الدوري وتحسين نمط الحياة، زي ما يقولون الوقاية خير من العلاج. ما ادري من فين طلع. وانقاص الوزن قد يحمي منه بمعدل 60، يعني الرياضة والصحة من غير العلاج ممكن يحميك من السكري بإذن الله. ركز دكتور زياد الرئيس في محاضرته عن الأدوية الجديدة، وميزتها أنها ممكن يكون فيها إضافات أخرى، مثلا زيادة الوزن مع السكري، أو اللي يكون عندهم أمراض في الجهاز الدوري الدموي والقلب، مع ذكر الأهم الآثار الجانبية اللي ممكن تأتي مع جميع هذه الأدوية. بالنسبة لمحاضرة الكارديولوجي، مستجدات أمراض القلب، again as a primary care physician، الرياضة المنتظمة والامتناع عن التدخين والغذاء الصحي على المدى البعيد. أهمية أن نأكد على هذا على المجتمع، أفضل من أي دواء للوقاية، طبعا هو أفضل وأوفر من أمراض القلب والجهاز الدوري الدموي. نصيحة مهمة لمريضي القلب بالانتظام على الأدوية. طبعا اللي ربي يكتب عليه المرض المفروض يكون يأخذ أدويته بانتظام لتجنب مضاعفات المرض، as to prevent tertiary prevention. بالنسبة لمحاضرة مستجدات الأمراض الصدرية والتنفسية، التدخين بنوعيه الإيجابي والسلبي يؤذي خلايا الرئة عبر السنين ويؤدي لصعوبة التنفس والإعاقة للرئة، وأهم علاج له هو الإقلاع عنه. مرة أخرى التركيز على الوقاية والطب الوقائي. لمريض الربو من المهم بمكان الالتزام بالدواء والأخذ في الاعتبار تغير المواسم وتغيير الجرعة. هذه أحد الأشياء اللي نواجهها من المشاكل مع مرضى الجهاز التنفسي الربو، خاصة عدم الانتظام على الأدوية، فيؤدي إلى أنهم يذهبون إلى المستشفى والطوارئ بكثرة، فالاهتمام بأخذ الدواء. بالنسبة لمحاضرة الثيرويد الغدة الدرقية، نصيحة عند ملاحظة وجود التورم في الغدة الدرقية ومكانها في مقدمة العنق، فعليكم مراجعة الطبيب المختص بأسرع وقت. احتمالية أنه وجود أورام قبل أورام لا سمح الله. زيادة الوزن أو نقصانه لا تعني دائما وجود مشكلة في الغدة، فهناك العديد من الأسباب التي تؤدي إلى هذه الأعراض. هذه من التوصيات التوعية بالمفاهيم الخاطئة في الناحية الطبية. بالنسبة للهايبرتنشن، ارتفاع الضغط الشرياني، يعرف ارتفاع الضغط الشرياني بالقاتل الصامت، ويصيب شخص من كل 4 أشخاص عالميا، ويعتبر سبب رئيس لجلطات القلب والدماغ. والمملكة العربية السعودية من هذه النسبة، وربما يكون أكبر من كذا. كتعريف للضغط أنه لابد يكون ضغط أقل من 120 على 80، ويجب فحصه بشكل دوري. الوقاية مرة أخرى أهم من العلاج. والحمية الغذائية قليلة الصوديوم والغنية بالبوتاسيوم، وممارسة الرياضة وإنقاص الوزن يقي من ارتفاع الضغط ويحافظ عليه. بالنسبة لمحاضرة البريفنشن ميديسين، تفعيل طب الدوري الوقائي على جميع فئات المجتمع، حيث أن الطب الوقائي يساعد على منع حدوث الكثير من الأمراض المعدية، فالتطعيم يكون ضروري، ويمنع حدوث الأمراض المزمنة كالسكري والضغط وأمراض القلب، مما يحد من معدل الوفيات في المجتمع. وهذا الهدف الأهم بالنسبة للطب الوقائي، هي الحفاظ على الحياة. محاضرات اليوم كان عندنا محاضرة الأوستيوبروسيس، شهادة العظام، وهو مرض شائع وصامت، نسبته تصل إلى أكثر من 50% في النساء السعوديات بعد سن 50. للوقاية منه بالتغذية السليمة الغنية بالكالسيوم وفيتامين د والرياضة، خصوصا التوازن وحمل الأثقال، بالإضافة للمشي وعمل الفحص بالأشعة مع وجود عوامل الخطورة، واستخدام العلاج بشكل منتظم تحت إشراف طبي. الهايبرليبيديميا، ارتفاع الكوليسترول، نسبة انتشار ارتفاع الكوليسترول عالية وقد تصل إلى ثلثي المجتمع. الارتفاع يعني فوق الطبيعي ولا يحتاج العلاج، ولكن نسبته تكون عالية، وممكن البدء بقياسه من سن 20 حسب توصيات الجمعية الأوروبية. هذه نصيحة للأطباء ونصيحة للمجتمع أنهم يحرصون على الكوليسترول مع كثرة المفاهيم الخاطئة عن ارتفاع الكوليسترول. هناك بعض العلاجات الجديدة الواعدة بشكل حقن شهرية ولكنها غالية الثمن، واختيارها للحالات عالية الخطورة والتي لا تستجاب للعلاج التقليدي، فهي ليست تراديشنال، ما هو حاجة أنه علاج أولي. بالنسبة للسبورت ميديسين، الطب الرياضي مهم لتجهيز الرياضي لأعلى أداء من خلال عمليات الاستطالة وبرنامج الوقاية للاعب وتوعية الأطباء بالإصابات المتكررة أفضل علاج ممكن، خصوصا كثرة الحمد لله أنه بدأ المواطنين يمارسون الرياضة، فبالنسبة للفاميلي ميديسين برايمري كير سوف يواجهون كثير من الإصابات المتوقعة في المستقبل. الوصفة الرياضية للبدء بممارسة الرياضة هي طريقة علمية خاصة بالأطباء لتسهيل الأهداف للمريض من أجل مجتمع صحي، وتشمل مدة ونوعية الرياضة وتكرارها خلال الأسبوع ومعدل اللياقة المطلوب. بالنسبة للجي آي أمراض الجهاز الهضمي، تحدث الدكتور محمود عن الأشياء الشائعة. مريض القولون العصبي قد يستفيد بشكل كبير من حمية الفود ماب، تم شرح ما هو الفود ماب وتوجيه مقدمين الرعاية على المواقع الاجتماعية عشان معرفة الزيادة عن الفود ماب، التي تشمل الإقلال من الكربوهيدرات والسكريات قصيرة السلسلة. تشحم الكبد منتشر في المملكة وعلاجه عن طريق تقليل الغذاء المحتوي على الكوليسترول والرياضة. الفحص الوقائي من سرطان القولون في غاية الأهمية لمن هم في سن 50 بشكل دوري. للأسف في المملكة العربية السعودية نسبة سرطان القولون مرتفعة. بالنسبة للأمراض التنفسية، الاكتئاب عفوا النفسية، الاكتئاب في ازدياد في مجتمعاتنا مع زيادة ضغوط الحياة المدنية. الانتكاسات في الاكتئاب عالي الحدوث، ولتجنبه لابد من اتباع الأساليب الجديدة مثل التركيز الكامل الذهن والعلاج السلوكي المعرفي. الفحص المسحي للاكتئاب مطلب رئيس من طبيب المعالج لصعوبة التشخيص وأثره السيء على الأمراض المزمنة. دكتور قصي كان أعطانا محاضرة درماتولوجي just now، ومن المقترحات عند ملاحظة طفح جلدي خصوصا إذا استمر لفترة طويلة تزيد عن أسابيع أو كان يسبب ألما، فعليه مراجعة طبيب الأسرة أو الطبيب المختص. إذا لاحظت تغير في شكل أي وحمة جلدية فعليك بمراجعة الطبيب بشكل عاجل. كما ينصح باستخدام الكريمات الواقية من الشمس عند تعرضك لأشعة الشمس لفترة طويلة، خاصة إذا كانت البشرة فاتحة. وأخيرا مستجدات أمراض كبار السن. كبار السن فئة غالية في المجتمع، رعايتهم الطبية تتطلب مشاركة الأهل والمجتمع مع طاقم الطبي المتخصص في رعاية كبار السن لتقديم الرعاية المأمولة والتي تليق بهم. ختاما يشكر مستشفى الملك فيصل التخصصي ممثلا في قسم طب الأسرة والعيادات الشاملة الهيئة الملكية للجبيل، وبالخصوص المدير التنفيذي المهندس مصطفى المهدي، والشكر موصول لمدير عام البرنامج دكتور محمد المقبل، وكذلك قسم التعليم والتدريب الطبي ممثلا بالدكتور عبد الرحمن المطيري، وجميع من أسهم في نجاح المؤتمر العلمي، والشكر موصول لكم جميعا لحضوركم وتفاعلكم. جزاكم الله خير. آخر محاضرة عندنا إن شاء الله ما نطول عليكم هي عن الجيرياتريك. I hope you know me now. My name is Dr. Loiba Sudan. I'm a consultant with family medicine and geriatric. For sure, geriatric as a topic and updated is long. I cannot make it brief in 30 minutes or 1 hour or 2 hours. So when I try to prepare the lecture, a lot of idea, that's important. So I ending by a lot of slides, but I will go through it in brief, and I will try to concentrate in لا الجيرياتريك هذا حاجة and if you have any question then we can discuss it in detail inshallah. Geriatric as a definition, the geriatric is by definition WHO they said anyone above 60 is a geriatrician. American Geriatric Association and most institute is calling by age more than 65. But definitely I have really patients in their 80s and they're completely independent. And I have patients in their 50s and unfortunately in wheelchair and they are dependent in their basic daily activity. So I think but when you get older we need more, and if we take good care of ourselves, the age is just a number, it doesn't mean anything. If you start to become more dependent, If you are unfortunate and you lose the memory and become dependent on your family or others, then your geriatric syndrome is start, and you need to get more attention from the family and from healthcare. Alzheimer, because a lot of people link between old age and Alzheimer. This is somehow true, because Alzheimer is coming with age. It's not only memory problem. It's in the beginning is a memory problem, but when you get advanced, it's completely become dependent, bedridden. You cannot eat, unfortunate for the patient, and it's number 6 causing of death in geriatric. So it's not only memory; it can cause death. 16.1 million American provide unpaid care for employee with Alzheimer. So with the family or taking care of Alzheimer, advanced Alzheimer, it's work and it's causing a lot of time and money. I like this, between 2000 and 2015, as I mentioned in prevention lecture yesterday, number 1 cause mortality up to today is cardiovascular disease. But we did a lot of improving in mortality. So the death from coronary artery disease is decreased. But for Alzheimer, unfortunate, the number is increased significantly. 1 in 3 seniors died with Alzheimer or another dementia. It kills. You know that dementia is a lot of types. There's 7 or 8 common types, but most 70 to 80% of dementia is Alzheimer. So Alzheimer kills more than prostate cancer and prostate cancer together. So it's a deadly disease, unfortunate, common in geriatric, and when you diagnose it early, you save money and give the geriatric patient a decent life. How much is the percentage in Saudi Arabia? I've been part of this research done in King Faisal Hospital with Dr. Abdullah Al-Khanazan and one of our residents. The percentage of dementia is about 6.4. This is almost similar to worldwide dementia. And MCI is mild cognitive impairment. This is the stage before dementia, is a little bit higher, 38.6. The unfortunate thing about Alzheimer, we don't have a treatment for Alzheimer. The only 2 types of medication is available for Alzheimer is acetylcholine esterase inhibitor and memantine, and both of these medications are not treating Alzheimer. It may decrease the progression of the disease. And the only medication coming in the market, the last medication in 2014, is to combine these medications. So it's important if you give the patient or you're dealing with patient with Alzheimer to know that this medication, it may help, but it will not treat the Alzheimer. So when you diagnose with Alzheimer, mild, moderate, or advanced, there is no going back from Alzheimer. You're trying to give him decent life by keeping the function as it is. There is a hope, and there is a lot of, the good thing that we understand now how is the protein in the brain affecting the memory, and there is some medication, hopefully by the end of this year, is coming, is in stage 3 in the treatment. There is some vaccination attacking the other protein, the tau protein, and hopefully by next year will be available. There is a lot they're talking about vaccination, about a lot of diseases. One of it is Alzheimer, so hopefully they will discover vaccine so all of us, we can take it and prevent from Alzheimer. There is another medication, anti-inflammatory medication. It's all under study, nothing approved. So up to today, as a member from Alzheimer, Saudi Alzheimer Society, I'm telling you there is no treatment, nothing approved up to now. There is a lot of study about Alzheimer. One of the study that, as Dr. Junaid, when he talked about hypertension, about the spirit, that strict control of blood pressure and the outcome, they found that if you make the blood pressure well controlled, it may decrease the risk of mild cognition impairment and dementia. So it's better to make your blood pressure systolic below 120. It may protect you from Alzheimer. There is some study, for sake of time, about, it's only some information, is nothing approved about early menarche, late menarche, miscarriage. It may link to the Alzheimer. Moving to the other big topic with Alzheimer is with the geriatric patient is polypharmacy. As you know, when you are in 70, 80, unfortunate, especially in Saudi Arabia, a lot of the patients, they have diabetes, hypertension, hyperlipidemia, they may have stroke, MI, so they come to clinic with 10, 18, 15 medication. This is risk of interaction between the medication, creating more side effect. What is the definition of polypharmacy? They said 3 medication or more. Some they said 5 or more. But for sure, if your patient taking any medication inappropriate or he taking medication with the same class, this is a polypharmacy, and you should, as a primary physician, family medicine, you need to take care of that. Even if you are not a geriatrician, but a lot of your patient is a geriatric, and you need to be sure what is the medication they're taking and the dose appropriate or not. There is a lot of tools that can help you as beer criteria. We have the beer criteria 2012, 2015, and we have 2019 recent. The 2019, for example, they say tramadol, you're supposed to avoid it in geriatric because risk of hyponatremia. Antibiotic like Bactrim can cause risk of hyperkalemia, so you need to be careful with renal failure. And there is a lot of recommendation, and their recommendation is either to avoid or use with caution. So it's available online. There is another guideline. There is a tool is called Start Medication that encourages you to start the medication of geriatric. Don't be, in contrast that they're taking too many medication, we don't want it to prevent him from benefit from medication. Patient has a stroke, we're not saying you don't use aspirin because you're elderly, you know the risk of another stroke is high, so you need to be careful with that. So I encourage you to review the beer criteria, the start and stop tool to help you to guiding treating the geriatric patient. We have a good talk from Dr. Ziad yesterday about diabetes. Just a few points when you're dealing with a geriatric patient with diabetes, because it's common. The ADA in 2019 and 2018 and 2017, they said you need to take the patient of geriatric as a whole. A lot of medication for diabetes will prevent the complication of diabetes after 10 years, 15 years. This is not the case when patient is 70, 80. So you want decent light, you need to see how is the patient function. Is he function and he's independent, then you may treat him strictly as other patient. But if the patient starts to be dependent, you don't want to restrict him with the medication. The strict control may cause coronary artery disease as MI or stroke. So you need to be a little bit lenient with this patient. As you can see here, if the patient they up to 7.5, if he is healthy, the geriatric, when he become more dependent, is hemoglobin A1C, this is the average of blood glucose, up to 8. If he is dependent on most of his daily activity, it's up to 8.5, it's fine. Metformin still is the first line for geriatric patients, except if they have renal failure and their GFR is below 30 is contraindication. TZD like an Actos, you should avoid it because of hypopholemia and the congestive heart failure. Most of our geriatric patients, they have some sort of congestive heart failure and risk of fracture. Sulfonylurea, risk of hypoglycemia. If you will use it with caution. The new medication, the DPP-4, is good medication with less side effect. They no need for supervision from the family at home, so it's good medication. GLP-1 is injectable, but is a good medication, but it can cause nausea, vomiting. A lot of these geriatric patients, they are not eating well, so you don't want to give him medication that will lose the appetite, so you need to be cautious with them. The new medication, the SGLT1, is good oral route. There is no, is orally taken, is make it easy for geriatric, but there is no study specified for geriatric, and it's diuretic. It's good with the congestive heart failure, but you need to be careful. Insulin, once a day insulin is better than multiple injectable dose. Again, we don't want a strict control, so you need to be a little bit loose with this patient. You don't want him to have blood glucose of 500, 600, but for sure you don't want him to be hypoglycemia, and you want to make their life is easy. Hypertension in elderly, we have a good talk from Dr. Junaid. I like, this lecture is just to review some point. So nice, the guideline for hypertension, the GNC 8, I'm sorry, the last one, they said, they specify if you are 60 or old, your blood pressure, you don't start the medication until 150. A lot of people got upset. They have this article that is review article about blood pressure strict control, as Dr. Junaid mentioned Sprint trial a lot. This is takes Sprint and another studies that to see the outcome. Is it better for geriatric patient to strict blood pressure or to be lenient, as the GNC 8 said, as you can see here, and the cardiovascular risk, mortality from cardiovascular, myocardial infarction, And heart failure, there is benefit when you make the blood pressure for geriatric below 120. Even there is some benefit from stroke, but it's not passing the median score here, so it's not statistically significant, but it's clearly for cardiovascular, from the heart, there is a benefit when you make the blood pressure below 120. When you make the blood pressure strict and blood pressure less than 120 in geriatric, that means you need to use more medication, so that will increase risk of side effect and renal failure. So in the conclusion, you will decrease by 29% the major adverse cardiovascular event. You will decrease the risk of cardiovascular mortality by 33%. You will decrease the heart failure by 37% if you make the geriatric patient blood pressure below 120. On the other hand, you increase the side effect, renal failure, make him use too many medication. We just mentioned something about polypharmacy. So sometimes you need to take it individualized. And it's not easy decision, but you need to make it individualized. You see the patient preference, the patient level of function, and then you make the decision to make it strict or not strict. Even the guideline is different between 120 to 150 to start the medication. Statin is interesting because we have a lot of guideline, European, British, American, and when they come to deal with the geriatric patient, the cutoff is different. Some of them, they cut off for their recommendation up to age of 65. Some of them have 75. Only the NICE guideline, they go up to 85. And we know that people living more and more, and we have, personally in my clinic, I have a lot of patients, they are healthy in their 80s. So when to start the medication, when you're looking and want to stop the medication, and how to deal with the patient if mainly for primary prevention when he is in their 80s, is different. Each one has guideline, and it's difficult for, if you take this as an example, if you have a male male and his blood pressure is 135 and his good cholesterol is 37, he's white, and he's smoker with total cholesterol, and he's not diabetic, and he's not hypertensive. If he is at age of 56, all the guideline there is some recommendation, and for this number, if you calculate it, every guideline will ask you to start the statin, except the European cardiovascular recommendation. The number is low, the risk, so they recommended not. When you move to age of 66, this recommendation is finished, and then at age 76, most of the guideline, there is no guideline, nothing guiding you what to do. You need to make it, again, individualized when it comes to geriatric in their 70 and 80. Just keep in mind, most of the patients, when they have the stroke or MI, they will not die. The number they dying from cardiovascular event is small comparing to disability. And we come to all these patients and ask him how you feel that if you live with disabled, they will prefer to die. Then they have a stroke and they cannot move half of their body, or they cannot eat. So, and we know that the statin can help to prevent this stroke. And the number need to treat is become small when it's become to geriatric patients. So there is a clear benefit from giving this medication. On the other hand, as you know all, and we talked, Dr. Junaid, about muscle discomfort, statin-induced diabetes, a small risk that it can cause diabetes, polypharmacy, all this you need to consider. Again, patient preference and patient level of function and cognition. Aspirin, the American Task Force, as I mentioned yesterday, they still, if you are age 50 to age of 74, they said if you have risk factor and your calculation risk cardiac assessment more than 10, they recommended aspirin. Last year we have this the ASPRI trial that mentioned that the risk of this is the aspirin and this is the placebo. All the risk in aspirin side effects is more cancer, because if you go to the American Task Force, they recommended to take aspirin not only to prevent cardiovascular disease, but they said also to protect you from colon cancer. This article showed that the risk of cancer in patients taking aspirin is higher than placebo, although it's not that significant statistically, but the number is more. The thing that is really significant is the cardiovascular disease, including ischemic stroke. That is, with aspirins become less. This is as a benefit, but in conclusion, the risk of bleeding in the brain become more, the risk of cancer become more. So now the conclusion is higher all-cause mortality was observed among apparently healthy older adults who received daily aspirin than among those who received placebo. So mortality become more in the group that taken aspirin. The number of bleeding in the brain become more. So there is, in the conclusion for primary prevention, you need to be careful when you prescribe it. For secondary prevention, if your patient has a stroke or heart disease before, mainly coronary artery disease, the patient should be in aspirin or Plavix. Fall prevention is common. We see it in emergency a lot, and they have femur fracture, and they have femur fracture, especially if they are osteoporotic, their life is changed. 30 of them, they will die from the hip fracture. 30% will become disabled. They will become bedridden from that. So physical activity is a must. And still the recommendation for geriatric is 30 minutes a day for 5 days. This is the minimum. Multidisciplinary, when you involve the other, if you have it, is better. If you check the balance, you suppose in geriatric clinic, we check the balance, the vision, the blood pressure, the orthostatic hypotension, what kind of medication that can fall, cognition, psychological health, all of these you need to consider it to prevent fall. Other thing that patient is not osteoporosis. Patient doesn't have low vitamin deficiency. If your patient is geriatric and has normal vitamin D and you have no osteoporosis and no prior fracture, the risk of kidney stone is high. So you should give him vitamin D or no. This is, again, American Task Force against to give for prevention of osteoporosis. Sorry, Dr. Shakir. Proton pump inhibitor is Dr. Mahmoud mentioned about this study in BMJ and the risk of death. Just again and again, we're using proton pump inhibitor as Nexium and Losec as a candy. All the patients, they taken it and we prescribe it. When you prescribe them, the good medication, unfortunately, you have a lot of side effect, and then you prevent the patient in need of the medication from taking this good medication. The side effect of proton pump inhibitor is interstitial nephritis, chronic kidney disease, dementia, hypomagnesemia, C. diff, a lot of side effect. So again, as I mentioned, we use it a lot because it's a good medication, but we use it with purpose or no purpose. So the number of mortality increase with number of days, Dr. Mahmoud mentioned, use it for short time with good indication. This is comparing proton pump inhibitor with H2 blocker, Zantac. They draw the Zantac from the pharmacies now, but the mortality with proton pump inhibitor was higher. Last thing, I want to just few slides about testosterone in adult men. As you know, when you get older, the level of testosterone for you become small. Is it good to check testosterone level for our geriatric patient or no? This is the details about the study. So this in New England Journal, they study the testosterone for 3 things for geriatric patients: the primary outcome of the sexual function trial, the primary outcome of the physical function. Does the testosterone improve your sexual activity? If you have low testosterone, does it improve your physical function? And about your fertility, or how you generally will live, is it healthy or no? So you can see here the sexual activity is significantly improved with the group they receiving testosterone. The remaining physical activity and fertility, there is no difference. Asymptomatic men, age above 65, and this is the definition of geriatric patient. Rising testosterone concentration for 1 year from moderately low to mild normal range, from mean to 19 to 40, from low testosterone to normal level, there will be a moderate benefit. In sexual function, some benefit with respect to mood and depression symptom, but no benefit with fertility and walking distance. Just to know that testosterone replacement therapy has a lot of side effects. The mood will improve, the sexual function will improve, but it can increase risk of breast cancer in men, it can increase risk of testicular cancer, it can cause increased level of cholesterol, increased level of liver problem. So you need to use it with caution for the patient they need it. The increased risk of agitation. Another test about cognition function. Among older men with low testosterone and age-associated memory, this is in JAMA, impairment, treatment with testosterone for 1 year, there is no improvement in cognition. What about anemia? We know one of the side effects of testosterone, or one of the action, it will work in the bone marrow, will make the hemoglobin goes up. So it will increase when you give the patient testosterone. If it is like normal, it will be higher normal or high. So they recommended if the patient is geriatric and he has anemia and you don't know what is causing of anemia, you may consider instead of saying anemia of chronic disease to check the testosterone, maybe it's low and causing low hemoglobin. What about in bone density? Testosterone treatment for 1 year of older men with low testosterone significantly increased the bone BMD and estimated bone strength, more in the tubercular than peripheral bone, more in the spine than hip, a large, longer trial could. So it's little bit protection from osteoporosis, but again, this is a small study. It's increased the coronary artery plaque volume and it may increase risk of MI. So in conclusion, testosterone, it may, if you have low testosterone, it will increase your sexual drive, it will improve your mood, it will maybe preventing you from osteoporosis, it will improve your anemia, it will not affect your cognition, it may increase risk of MI, and for sure, as knowing, increased risk of cancer and liver disease. And thank you. Before we ending, is there any question about dermatology or geriatric? We can answer it before we conclude. Yes, please. You can say it for them. We can hear you.
Assalamu alaikum.
Salam.
I have one question about Alzheimer. Is there
Sure.
any way to prevent it? Like I've heard like learning new skills, languages, or play.
Yes, it's a big topic, Alzheimer. Yes, there is, first of all, the most common thing for Alzheimer to prevent the risk factor as diabetes, hypertension, smoker, not exercise. That's by evidence it shows decrease the risk of Alzheimer. If you keep your brain busy, like SCODO or كلمات متقاطعة, the word, yes, it will. The study say it may help to prevent Alzheimer or decrease. Yes.
Thank you, Dr. Rai, for this presentation. You are, as a physician, how you deal with the polypharmacy with your patient? And do you think when we cut the quarter of dose for geriatric patients, it can provide polypharmacy or control it? Thank you.
First of all, especially in Saudi Arabia, my biggest recommendation, ask your patient to bring all the medication at home. A lot of, unfortunate up to now, a lot of patients, they have multiple access to military hospital, National Guard, Ministry of Health, and they have in the same class like more of medication. And then take it one of the, why they are taking the medication. If the patient hypertension, as you mentioned, sometimes to make blood pressure below 120 is protection with polypharmacy. So you need to take it individualized. They need it? Is there any contraindication? They have renal impairment. Most of the geriatric, they have some level of renal impairment. And you need to have the GFR or the creatinine clearance. Is it suitable for them, this medication, or no? So what is the medication? Is they are taking multiple medication from the same class. What is the indication? Is it appropriate for them, the medication, or no? What is the level of living of the patient? If somebody come to you in wheelchair or you go in home health and visit him and he is bedridden, why I want him to be strict blood pressure control? Why I want him in strict diabetes control? Why I give him something for prevention? So I need to individualize it. Yeah, maybe I cut all the medication. Some of the patient I cut all the. What is the indication? Patient bedridden, and العلم عند Allah only. But we expect him medically he will die within 3 to 6 months. Is it worth to give him all the medication for preventing like high dose of statin or two medication for hyperlipidemia, 5 medication for diabetes? No, quality of life at this stage is most important. But this is not your own decision. The family need to be involved and you need to be wise.
Thank you.
Yes, Dr. Shakir.
Just maybe clarification about vitamin D.
I know it, yes.
Well, first of all, we know vitamin D will not prevent fracture,
Yes.
and we showed that. However, patients with hypovitaminosis D, we have to, give them the replacement.
Mhm.
Now, for osteoporotic patients whom we use anti-resorptive or medication, it's shown that without vitamin D, this medication will not work properly. So your patient with osteoporosis, if you give them the medication, it's necessary that at least they have the daily requirement of vitamin D. Different societies maybe have different recommendations.
No. Just to clarify, just to make it clear.
Yeah.
I mentioned clearly, if the patient with osteoporosis, if the patient has low vitamin D, or the patient has prior fracture, this is not included.
Okay. So thank you.
Yeah.
That's what I.
So if patient has prior fracture, just to clarify for everyone, if the patient has low
Yeah.
vitamin D evidence, or he has history of osteoporosis and medication, or he has prior fracture and he is above 65, please keep him in vitamin D. But if he is 65 or above and he doesn't have any of these problems, you need to just know that the risk of vitamin D.
Maybe the daily requirement. Why we have daily requirement from the American
Exposed to the
Society
sun.
of Endocrinologists?
Because the patient, they're not exposed to the sun. If they can,
Yeah.
Again, this is just a recommendation. This is from the American. This is not my recommendation. This is the American Task Force, and they put D, and as I mentioned, D is do not harm. So, you need to be careful. My message, I will not make it. Make it individualized. If the patient with osteoporosis, he should be in vitamin D. If he is not osteoporosis, the risk of renal stone is high, so you may be better not to give him. Thank you very much. Appreciate, and I hope you will get what you're looking in this conference. And please fill the form about how we did. And if there is any way that we can improve, we will really appreciate it. Thank you very much.
نتقدم بالشكر والتقدير لسعادة الرئيس التنفيذي المهندس مصطفى المهدي على رعاية هذا المؤتمر، كما نتقدم بجزيل الشكر والتقدير للمتحدثين والضيوف الكرام منسوبي مستشفى الملك فيصل التخصصي ومركز الأبحاث بالرياض، ونشكر الجميع على حضورهم ومشاركتهم. والآن مع تكريم المتحدثين فليتفضل سعادتكم مشكورا. الدكتور لؤي باسودان. الدكتور محمد الشاكر. الدكتور حسام جنيد. الدكتور محمد شفيق. الدكتور زياد الريس. الدكتور قصي العبد. الدكتور أحمد محمود. الأستاذة لولو وسهلي. وفي الختام نشكر لكم المساهمة في نجاح هذا المؤتمر، ونرجو لقاءكم في مؤتمر آخر إن شاء الله. الله يعطيك العافية.